Good morning, everyone. Thanks to everyone for getting up early. Welcome to the second day of the Edinburgh Orthopaedics and Sports Medicine Conference. Delighted to have everyone here. Just a few housekeeping things. I'd encourage everyone, if they can, to visit the posters. They're in the room as soon as you come down the stairs from here. It's the first on the left. There's some great posters, and we're going to announce the winners of the poster competition just after lunch, so it'd be great if you could do that. I'd also like to thank our fantastic sponsors again today, and if possible during those breaks, I'd be grateful if you could visit their stands and interact with them, because they've done a lot to support the meeting today. So without further ado, I'll hand over to Claire to introduce the first session.
And thank you all for joining us this morning to talk all things knees. It's my pleasure to introduce the first speaker of today's session, Dr. Carrie McRae. Carrie is a sport and exercise medicine consultant. She works with Sport Scotland Institute of Sport. She's worked in a whole range of different sports, including football and rugby, Commonwealth Games, British Olympic Association. So she's got an impressive CV and is very well placed to share her thoughts on initial assessment of the knee. Carrie, thank you.
Thank you very much for that introduction and for the invitation to speak today. It's been a great event so far, and I'm sure today will bring a lot more to the table. So I've got the next 10 minutes to open this session on knees by discussing the topic initial assessment of the acute knee. Now, clearly, this could occupy a far larger block of time, and with this in mind, there's plenty that I'm not going to cover. Rather than focusing on the finer points of anatomy or epidemiology of acute knee injury, I've approached this through the lens of the practical considerations of acute assessment in performance sport, and hopefully this will help set the scene for the topics that are going to come up in upcoming talks. So when we delve into the realm of acute knee presentations, we encounter a diverse array of possibilities. The true acute knee encompasses a range of potential pathologies, including ligament disruptions, fractures, dislocations, and it's not uncommon, unfortunately, to come across cases where multiple issues coexist, adding complexity to the diagnostic and assessment process. However, it's important to remember that an acute presentation doesn't always indicate an acute pathology. Chronic issues can manifest acutely as well, such as stress injuries, stress fractures, tendinopathy, and degenerative changes. Recognising and differentiating between acute and chronic conditions is obviously a crucial aspect of our ability to accurately assess and instigate initial management. In addition, we have to remain vigilant for the diagnostic zebras or red flags, particularly those that require immediate attention. These may involve septic joints, inflammatory conditions, reactive arthropathy, or crystal-arthropathy, which we do sometimes see in sport. Identifying these conditions amidst the more common knee ailments adds a layer of professional challenge. So it goes without saying that we need a way to sieve through the wide potential list of diagnostic possibilities. Adopting a structured and systematic approach helps narrow the differential list, enable further investigations to be targeted, and shape the early stages of effective management. I think it's important to also consider that our responsibility lies beyond the clinical, and that having a structured approach has organisational advantages as well, effective and appropriate use of financial and staffing resource. When we consider assessment, we could place significant focus on the point that we get hands on the athlete. And whilst this is clearly an important component of assessment, I'm sure that we'd all agree that a broader definition is more helpful and closer to what happens in real time and in real life. As has been mentioned by other colleagues, an understanding of the contextual factors around a presentation provides essential intelligence to assist in formulating a comprehensive assessment and early management plan. So I'm always a fan of thinking simply, and if we look at this through the lens of field of play cover, one of the key components of initial assessment is to answer what is, on the face of it, quite a binary question. Can the athlete stay on the field of play and continue, or do they need to come off? Whilst this is a simple question, there are a range of factors that can make answering it a little bit more challenging for us. On the other hand, if we make the decision that an athlete needs to come off the field of play, we've already passed through a couple of layers of our diagnostic sieve, which can help inform both immediate and delayed assessment. So drilling down a little bit more into some of the detail of field of play assessment, there are a range of ways that can support our ability to make a safe and measured decision. So imagine yourself in a field of play role at a major sporting event in a full capacity large stadium. You see a player go down with a knee injury, and in such situations it's really important to have a systematic approach to evaluate the severity and the nature of injury. And I think it's really important to remember that systematic approaches help us perform, particularly when the pressures are high. This might be a little bit too small for you to see in detail, but this is the UEFA Emergency Action Plan, which is described as a set piece, and it creates a universal language for us to work to, and credit to colleagues for developing this and helping work on the international stage to develop a systematic approach that we can all follow. In terms of the actual initial assessment, so this forms a key aspect that allows us to safely initially assess limb injuries, and a secondary survey then reduces the risk of missing an acute injury if it's not immediately apparent. So the mechanism of injury can obviously help inform our levels of clinical suspicion. This might be directly witnessed or be available in video feed, and it's important to remember that when we're on field of play or pitch side, the mechanism isn't always clear. It might happen in the scrum, it might happen because as medical staff we're required to sit in a dugout. Sometimes the pitch is not completely flat, which I know there's certainly a few in Scotland that are like that, or if a distracting injury has happened at the same time. How targeted an exam needs to be will in some part be determined by your role and the rules of the sport. Assessment might need to happen on the field of play, or there may be an opportunity to briefly assess via the side of the pitch. It's important to use all cues available to you, as it's not surprising that a lot of athletes won't want to come off, so seeing if they're obviously in pain will be one helpful initial assessment tool, and then obviously assessing pain, range, key structures, resisted movements and athlete confidence to return would all be typically part of the assessment. Functional testing in this setting would be applied to help determine if the athlete can go back on the field of play and therefore has already passed through the first steps of those. It wouldn't be particularly relevant to do a functional test if you've already determined that they've not passed the initial screen. As has been mentioned in previous talks, the assessing clinician would want to know if the athlete is able to complete the task of the sport safely, considering the demands, the time left to play, competition level and other factors. Even if the athlete is returned to the field of play, the performance team should continue to monitor for any changes. Video analysis can potentially add value during the acute phase. It depends on availability and how quickly you can access it, but is probably more helpful during the delayed assessment if it becomes available. Obviously, time can confer a range of advantages when it comes to assessment of the acute knee. It allows us to understand the behaviour of the injury, its response to early management, symptom development, the presence of absence of effusion, and the pattern of pain. With the delayed assessment, there's more time to reflect and review on the mechanism with the support of video analysis or from collateral history from the athletes or from other members of the performance team. Examination and functional assessment can also benefit, obviously, from the additional time, and this is often conducted in a joint basis with the treating physiotherapist and SEM practitioner. The patient's more likely to be able to provide a coherent history when you take away the distraction and distress of acute injury, and this also provides an opportunity to understand the athlete in the context of their injury and to perform an appropriate biopsychosocial assessment. Athletes can experience a trauma reaction after acute injury, and it's important to understand the context that they've experienced their injury in. Once a diagnostic formulation has been complete, it would then be appropriate to consider what else might support the diagnosis or support next steps in management. Clearly, this might involve referral for radiological investigations and further to orthopaedic opinion, but it's important to not think that that's the only referral that might be appropriate. There may be other factors of influence that might instigate referral, for example, performance nutrition in the presence of a stress injury or stress response, or performance lifestyle if we have a youth athlete who's perhaps sitting exams at the same time, hence the need for the biopsychosocial assessment. Depending on the timing and the location of injury, the support team around the athlete may have variable knowledge about what's happened, so it's important not to assume the communication has happened. Providing timely updates and adopting a proactive approach around modifications to support adapted ongoing training and early rehab planning is important at this stage. If we were to focus a little bit more on the context of acute injury, there's a few points worth highlighting. Acute assessment is clearly going to differ depending on whether you're performing this on the field of play or the relative luxury of a medical room. And even if it is post-match game competition, particularly in away settings, the environment for assessment is frequently not ideal. Our ability to perform a robust assessment can be heavily influenced by field of play rules, and this will be determined both by the sport and the competition rules. Some sports permit assessment on the field of play, others don't allow entry onto the field of play without disqualification of the athlete, and some will have independent medical staff or field of play teams who would act as the primary assessors of injury. Role clarity, particularly when your field of play is essential, being clear whether you're the first clinician on or if there's any limitations to the doctor entering the field of play or if there's any accreditation limitations. This obviously may adapt if multiple injuries occur, but it does require a robust pre-event planning and communication. How an assessment is formulated will be influenced by in-competition and out-of-competition factors. It may also affect how and when the athlete is assessed, with regular practitioners who normally care for that athlete potentially assessing later during the course of injury. If we think about domestic and international factors, with high levels of international competitive demands, many injuries happen away from the domestic situation. This can add assessment challenges of remote or delayed assessments by the regular clinical team, navigating unfamiliar healthcare systems, language barriers, and sometimes, as you would expect, increased stressors for the athlete. When we consider wider contextual factors, there are, of course, plenty for us to think about, but this table gives a flavour of some of the other considerations. We will, of course, take into account the age, biological sex, previous injury history when considering both the prodrome to injury and also the acceptable tolerance of risk when formulating a plan. How pain and injury presents may vary according to the athletes and the sport that they compete in, a point made easier to assess if the athlete and the sport is known to you. Previous significant trauma or psychological history may also influence the presentation. As has been mentioned several times already, the nature of the sports, level of collision, contact, and risk frames some of our expectation of what we're going to see injury-wise, which in turn impacts on our preparation. Whilst we tend to focus heavily on competitive demands, one thing we often do see is the issue around selection windows. So in order to be able to compete, athletes need to be selected, and there's often a balance to be struck on how we best enable an athlete to perform in the face of an acute presentation without overly compromising the competition they hope to be selected for. When we consider performance factors, it's understandable that the acceptability of risk for an elite athlete competing in a target competition is going to vary from a youth development athlete. But I think we need to be careful about the concept of informed consent. It needs to be carefully considered in this context, and particularly if there's any age or power differentials or any other issues around capacity. Shared decision-making should include the athlete and key members of the MDT team. No clinician is or should be an island, and injury assessment is no different. Acute and significant injury is a journey for any athlete, and as clinicians, we may come in and out at different points or multiple points along their timeline, and the athlete is the constant. It's really important that we remember that. It's important as a key practitioner that we understand which part of this timeline we've come in on and ensure that we both receive and impart information in a cohesive and collaborative way. And it's inherent on the clinicians leading care to help coordinate different inputs, manage communication, and ensure consistent use of language and messaging. One key strength of the multidisciplinary team is the ability to check and challenge and to add diversity of experience and perspective, and these are inputs that we should welcome. This process should be considerately managed and shared so the athlete can benefit from gold standard multidisciplinary support. So, in summary, no two injuries are the same. Consider all available context when assessing the acute knee. Use all the clues you can find and adopt a systematic approach to help you. Understand your role within the high-performance team. Each discipline has an important role to play. Understand your own role and the roles of others and work together to optimise care. Communicate effectively and foster the same in others. Consider the most effective forms of communication for the context. Many thanks for your attention, and I'll now hand over to Claire.
And it's my pleasure to continue. While I've got the mic, I may as well use it. And I'm going to introduce our next speaker, Dr. Andy Williams, who comes to us from London, the Fortis Clinic in London. And Andy will be a very familiar name to many of you who are working in ACL, I was going to say rehabilitation, but ACL broadly. Andy's done a ton of work and has really helped us all learn about ACL reconstruction and how we can best care for athletes. And he's going to speak about ACL reconstruction, when and how. Thank you, Andy.
Thank you very much indeed, Claire. It's a massive pleasure to be here. Fantastic venue, great course. I must thank everybody for inviting me. Now, I'm going to give you my very surgeon-biased view, which obviously I respect, but you'll be pleased to hear that this slide was prepared before Claire's talk, and not every ACL reconstruction needs surgery. At times you might think that's what happens, particularly in London. Middle-aged, overweight, unhealthy skier blows their ACL, they get an operation. Well, what I would say is that most young active patients do best to have a good ACL reconstruction. I choose my words very, very carefully, because the worst thing is a bad operation or an unnecessary one. And there certainly is a lot of unnecessary surgery and sadly, a lot of bad surgery. But if you go for non-operative treatment, it's actually really hard work because, as Claire has highlighted, it has to be high quality. You have to follow patients carefully. And one of the worst scenarios is seeing a kid who has a physician or surgeon who's obsessed with the non-operative approach. And I'll get my coat. And they preside over this knee in a stepwise deterioration with meniscal and chondral damage. But as Claire said, if you're alert to it, you don't have to have that happen with non-operative treatment. Now, for the surgeons in the audience, I just don't see the problem with ACL reconstruction. It really is very, very easy. You've got to execute these 7 steps. You've got to choose the right patient. You've got to choose the right time. You've got to choose the right graft. You've got to put that graft in the right place, fix it properly so you can rehab them. You've got to de-stress the ACL by addressing other lesions in the knee, which will be covered by the speakers later on. And then, critically, you've got to organise the right rehab. It is as simple as that. And yet we have conferences debating where to put the blinking thing. So my ideal patient, I believe, is a high-level athlete. That's pretty easy, I think. If a patient has symptoms of instability, having had non-operative treatment, if they have persistent swelling, one should not accept a swollen knee as being okay. And if you can establish progressive damage, such as meniscal or chondral problems related to the ACL insufficiency, those cases, I think, would do best with a reconstruction. I also would say, and this is more controversial and perhaps reflects my enormous bias, but those who want to get back to stressful activity may do well with an early reconstruction. And also, I believe children and adolescents, and I know people in the room who wouldn't agree with that, but I believe that's the case. That's a belief, not evidence-based. The right time for surgery is when the knee is quiet and there is no rush. Unless you've got a locked bucket handle tear of your meniscus, you don't have to rush into surgery. The prerequisites for surgery are to have full active as well as passive knee extension, flexion over 90 degrees, and a quiet joint. If you operate on an angry, stiff knee, it'll never bloody move again. So just take your time. And even the elite athletes, and I have a bizarre life, I say 80%, but probably 90% of my work now is pro sport. Even they are human, and they have to wait. And I think we have managed to educate the various teams and other people involved that waiting will save time in the long run. The best graft is obviously a patella tendon. It's fantastic. 2 little bits of bone either end, heal rapidly. Beautiful tissue that inserts onto those bone plugs. It is the best graft. But arguably comes with a bigger price than other grafts that are often very good, like hamstrings or quad tendon. Now, I've got no experience with peroneus longus, but in the Far East, that's quite a popular graft. What I hate is allograft, and I almost never use it. But even that has a place. If you have an inline power athlete, you don't want to rob them of any power using autograft. And so the poor woman here who can't jump very well had an allograft ACL reconstruction. And she's now 15 years out, still competing, and has managed to win bronze medals at 2 Olympics and silvers in the World Championships. If I'd taken autograft, she would have lost power and speed. So even the graft I don't like very much has a place. Where do we put it? Well, in the tibial side, I think that's pretty standard. Most of us aim for the center of the so-called tibial footprint. But the femur is where the controversy occurs. And ladies and gentlemen, those of you who aren't involved in surgery have been blessed to avoid a 30-year discussion and navel-gazing regarding where we place the graft. Now, Charlie Brown very kindly gave me these cadaveric photographs. The arrow and the oval outline the so-called footprint of attachment on the femur. Traditionally, we went to the AM bundle position, which is the red area on the picture. And then there was some enthusiasm for placing a second graft, so a double bundle, to cope with not only the anteromedial bundle, but the posterolateral bundle of the functional units, if you like, of the ACL. But when the results weren't much different to single bundled procedure, a lot of the surgeons who liked that concept placed their graft in the center, and they brazenly called it anatomic reconstruction. As my view is anything in the footprint is anatomic, but we'll come back to that later on. So if you do a double bundle, you can see that the tunnels aren't that close together, and even a central versus AM bundle is a fair distance between them, and that is likely to affect the results, as I'll show you shortly. Now, what about graft fixation? Well, the fixation needs to be adequate to allow rehabilitation and to stimulate healing. Now, this is a case report from my fellowship in Brisbane, Australia, and this young man, had to be a lawyer, obviously, presented 2 weeks post-surgery with discharge of a hematoma from the wound over the upper tibia. At 6 weeks, it was still discharging, and my boss got a sinogram. You might not be able to see it, but there's a catheter coming in, and the radiologist fed it in, and hit a popliteal vein. So you can see a popliteal venogram. You can see dye going through the middle of the knee and the line of the ACL. And arranged for surgery the following day. He opened the wound, took the tibial screw out, well, it basically floated out, and then kept curetting out graft, flushing and flushing. When the fluid came out the same color it went in, he sealed the wound and popped a scope in the knee. What do you think he saw? Unbelievable. A beautiful ACL graft 6 weeks post-op. So this graft has become a tube. You saw that dye going up through it. And it's beautifully healed at the aperture. So at 6 weeks, this guy had no graft, no fixation in his tibia, but went on to get a great result. So I believe, I've got no evidence base, but I believe in aperture fixation and healing of grafts. We don't understand the biology of this operation. And so in terms of fixation, if it's patellar tendon, and I place 2 screws, that's pretty straightforward, and you get a nice rigid fixation, they heal quickly. But for soft tissue graft like hamstring, my preference is to get aperture fixation with a screw. The problem is if you just use a screw, it has to be quite tight, and I used to damage some of my grafts. So I now use hybrid fixation with a suspensory, with the use of an endo button, because it's very, very powerful for pull-out, and then a screw that's not particularly big, but just stabilizes the graft. This, ladies and gentlemen, is witchcraft. I've got no evidence base, but there's logic to it, and the logic is that it shortens the working length of the graft because it is fixed at the apertures compared to pure suspensory fixation. If you have a stretchy thing, the longer it is, the more it stretches. So I believe it's a good thing. And on the tibial side, I use as big a screw as I can, a big fat screw to compress the graft. Now, I have a very strong bias, and I'll mention why later on, but I do not like bioabsorbable implants. Metal is reliable, it's cheap, and it's a strong preference. I have to concede that PEEK may be the optimal choice for implant material, but bioabsorbables don't bioabsorb and become bone. This screw was removed 5 years after implantation, showing very little sign of degradation. They're very expensive, they're brittle, they break, they are often matte surface, they spin grafts, they grip it, and tunnel widening has been associated with them. So I don't know why people use them, and they're unbelievably expensive. The de-stressing of the graft will be covered later on, but one thing we've learned in the last 10 years, maybe 15 years, is not just to look at the ACL, but to look at the peripheral collateral damage, if you like. Deal with the meniscal tears. I may add a lateral extra-articular tenodesis. I'm currently obsessed with the medial collateral ligament, and I think one of the most common reasons for good ACL reconstruction failing is unaddressed medial laxity, and even osteotomy has a place. And finally, we've got to get the rehab right. There are many people in this room, physios, sports physicians, who've made me successful because they're so brilliant. There are one or two people, I'm pleased to say, not in this room, who've made me look useless. So you've got to be, as a surgeon, interested in the rehab. It seems to be a relatively uncommon trait. You've got to communicate with each other and work together in a very combined fashion to get the best outcome for the patient. Now, what's the evidence for this? Well, all I can do is present my experience, which is unusual because it's so heavily biased to pro athletes, and 90% of these athletes are male, tragically. And so there is a massive issue with what we've learned, really. And we've produced a series of cases, 232 pro footballers, as another cohort of 200 athletes. And the return to play, as Claire said, is spectacularly good in pro athletes. The general population have about a 50-50 chance of getting back to pre-injury level of activity. But this group of people have to get back. They have the best rehab, they have the best motivation, and they do get back. We've just submitted a paper, as Claire has intimated, on longevity, and it does fall off, but that Volden paper that was shown, actually results are better than that. But with time, they do lose career length, and they do lose level of play. Even revisions we can get back. The factors that seem to mitigate against return to play are the older athletes, certainly in football, and maybe that's because they are close to retirement, have had enough, and their best days are behind them. If they have a second operation, or if they have meniscal surgery at the time of the ACL reconstruction, all three of these factors take off about 10% return to play. And I hesitate to say, but the under-25s in the 232 football series amazingly had a 99% return to play rate, which is scarily high. Interestingly, there was no effect of the graft choice, the femoral tunnel position, or whether or not a tenodesis was used when we're talking simply about return to play. But in terms of graft re-rupture, we have this dramatic graph. The black columns are for hamstring grafts. The mauve ones, or light grey, are for patellar tendon graft. Now, I traditionally used AM bundle position, which are the two middle columns, but I was convinced by some very good people, based on their research, to move to the so-called anatomic central footprint position that you saw earlier on. It was a disaster. My hamstring re-rupture rate is 18.5%. These are all pro footballers. The patellar tendon re-rupture was 10.5%. It wasn't sustainable, and I'd be out of a job. So thankfully, I went back to the AM bundle position. That's the two middle columns, 10% re-rupture rate with hamstring, and 7.5% for patellar tendon. But when we add a tenodesis on the far right, AM bundle position, patellar tendon with a tenodesis, the re-rupture rate is 2%. We've also looked at overall at a big cohort of my pro athletes, 455 of them, overall re-rupture rate of 7.9%, which is respectable. With a tenodesis, that rate was 3.4%, whereas without, 9.5%. So what would I say in conclusion? I would say that never-ending study and audit and looking at results will improve results because we can fine-tune. We can get really high return to play rates in pro athletes, although the general population is much less. And the graft re-rupture rate will vary according to the surgeon and their technique. And I would always advocate AM bundle position on the femur. And I add tenodesis in high-risk cases, and I would include athletes in that. So most of my practice involves a tenodesis. And in footballers, at least, patellar tendon wins. Now, very importantly, my bias is that I part own a company that makes those metal screws, so you have to take that into account. And those are my other disclosures. Thank you very much.
Thanks, Andy. So it's an absolute pleasure to invite Dr. Robert Laprade, who's come all the way from Minnesota. He's globally the most recognized name in knee ligament reconstruction. He's got a full-time clinical practice and in his spare time has published over 650 articles, the vast majority of which are new data. And I think his biggest legacy is that many of the people that have trained with him, whether it was in Minnesota or Vail, are now leaders in the field, and we'll see that with Nick and Andy Giesland later. So welcome, Rob.
Thank you, Ian. Thanks, everybody. It's a pleasure to be here. I appreciate all the work we've been able to do with you and your team, and hopefully more going forward, Ian. So I'll be talking about concomitant injuries with ACLs, and I agree with most of what Andy said, all of what Claire said, most of what Andy said. And then, and here's my disclosures. So the main goals I want to go through is to talk about some of the concomitant injuries that we've seen with ACLs and how to address them. Try to review how we work up these patients and kind of go through my thought process in evaluation of patients with ACL tears. So my background, I'm from Minnesota, as Ian said, married, 3 sons, 2 grandkids. The picture in the hockey game there is minus 25 Celsius. It was the coldest hockey game ever in a professional sports history, and that's all my family bundled up. But I am a full-time clinician, and most of my patients are revisions. So all of the patients I see in clinic are pre-screened ahead of time before I see them, just because I see so many revisions and have a busy clinical practice. But I've been able to surround myself with excellent people to help us do our research. So the topic on ACL tears, as Andy and Claire were just talking about, it's the most studied knee ligament. And if you look at putting together the information that's submitted to meetings with abstracts, almost half of the abstracts submitted are related to the ACL. So it's very well studied. And I think one of the issues to look at also is that it's rarely injured in isolation. I'll try to convince you that based on the data that we have. And it's important to recognize that revision ACL rates, depending upon your graft choice, bony alignment, and other issues, can be anywhere from 5 to 45%. So one point I would like to make out, it's very, very rare just to have an ACL tear in isolation. So you have to catch all the other things that can potentially go on to make sure that your ACL reconstruction is going to be optimized. So you have to be able to have a good evaluation of a tear. Now, if we can get this video to play, it's important when you see the Lachman's test. If we can get that to play in the back. Maybe I'll go back one more and come forward. When you do see a positive Lachman test, it's important to recognize if you do see a 3+ exam, that's not an ACL. It cannot be an ACL. There's more going on there. And if the pivot shift is a 3+, it's not an ACL. It has to be something else, and you have to be able to recognize that when you're doing the evaluation. So what are the things that we look at? One of them is to look at age and family history. Hyperlaxity is also important to evaluate in every single patient. The bony geometry, both in the sagittal and coronal plane, and then looking at meniscal pathology and concomitant ligament injuries. So age is important. Younger age, as we've seen, has a significantly higher predictor for ACL failure. And I'll tell all my patients that come in that are teenagers, there's a 30% chance they'll tear their ipsilateral ACL reconstruction or the contralateral normal knee. And there's enough data out there to show us that that is accurate. So about 30% of the time you have to worry they're going to tear their ACL. And then what Claire was talking about, the way that we minimize that is make sure they're appropriately rehabilitated before they go back so they minimize their risk of re-injury. And then another thing is to look at the optimal graft choice ahead of time and getting proper prehab and rehab for returning to sport. If we don't put that all together, that's a risk factor. Family history also is important. We found out that a family history of a previous ACL tear has a higher rate of re-tear, and that may be that when you add in your LET, or make sure you're always using a BTB like Andy and I do to increase the chances of having a success. Hyperlaxity is also important to evaluate. When you have somebody that has this much hyperextension, a hamstring is going to fail. So if you're foolish enough to use a hamstring graft for an ACL, then you really want to make sure that if you're going to do that, add an LET in this indication so it has a lower risk of failure. We know that graft choices are a huge factor on the ability to have a successful outcome. I have not used an allograft since before 2015. There's always a chance that you can find the correct graft. I haven't used the Peroneus longus, although I have studied how to harvest it if I needed to. But you should be able to find it, even in the patients that I see that have had 7 failed ACL reconstructions. Usually it's because they've been using allografts over and over and over again, and that's why they fail. Now, when we see somebody that comes in, our ACL workup has to include all these factors to increase the chance of success. We have to see if they've had partial meniscectomies, because that'll put extra stress on the graft. We have to look for ramp lesions. We have to look for root tears. We check their coronal plane alignment and their sagittal plane alignment and put all of that together to make sure we're not missing something. Bony alignment does have an effect on an ACL reconstruction. I get a long leg x-ray in everybody that I see. So all my patients get long leg x-rays, and we'll see if they're in varus or valgus alignment. Varus alignment increases forces on an ACL graft, and valgus alignment does too. So you have to put that in your evaluation of these patients. Tibial slope has a significant effect on ACL reconstructions, and most of us underestimated this in the past. But as the slope increases, it's going to increase the stress on the ACL, and when you have an ACL graft tear or an ACL tear, it's going to increase the anterior tibial translation. So we get a long tibial standing x-ray in every patient that has an ACL tear also to see how much translation they have. And veterinarians know that ACL surgeries don't work in dogs. So 25 years ago, most veterinarians figured out if they did a tibial leveling osteotomy, that's going to stabilize the knee. So it's the same thing for humans that we found out. And we've done the biomechanical studies on this and show as the slope increases, it significantly increases the stress in the graft. And the magic number we found in the lab was 12 degrees. And that is what we're seeing clinically also. Once you get above 12 degrees, it increases the stress on an ACL. And the clinical studies validate that. So the Australian study with Lucy Salmon showed with the chance of having an ACL graft fail with somebody that has a slope of 12 degrees or more at 20 years is almost 80%. So low success rate when you have a slope of 12 degrees with a hamstring graft over time. In our own clinical studies, we found out that as patients do have an increase in their slope, they do have an increased risk of ACL tears. So if we look at our patients that didn't have ACL tears and check their slope versus ACL tears, there's a significant increase there, and it didn't make a difference between gender or contact or non-contact. So the main times that we'll look at tibial slope is, I don't think there's a lot of indications for primary slope treatment. Charlie Brown has a different population in the Middle East where maybe he'll do some primary slopes. We don't do that very often. And then when you're having a revision ACL reconstruction, slope of 14 degrees or more starts to get to the point where we have to looking at doing a leveling osteotomy to take the stress off an ACL reconstruction. And then there's the posterolateral corners that Lars and I have worked on for many years. And we know that when you have a posterolateral corner injury, the increase in varus gapping laterally is what causes extra stress on an ACL reconstruction. And you can't just tighten the ACL down and assume it's going to take care of that varus gapping, because it'll overconstrain the joint and it'll cause it to fail. So when we do see a posterolateral corner injury with this lateral compartment gapping, we have to address that injury. So one of the ways that we can look at these clinically is to look at the varus stress x-rays. That encourage anybody that treats these to obtain varus stress x-rays, because There's a lot of physiologic laxity in patients, so you can have objective numbers to assess this, and also look at the heel height. So if they have more than 3 centimeters of heel height on the same side when you examine them, so the first thing I check in all of my patients is their hyperextension, because that gives me good information. If it's more than 3 centimeters, there's a pretty high risk that they're going to have at least an LCL tear in addition to having a posterolateral corner injury. And then, like Andy was talking about, the MCL has a significant effect on an ACL reconstruction. And in the past, the pendulum swung too far over to non-operative treatment, where we thought we could treat all of these non-operatively. We're recognizing that led to a lot of ACL failures. So we have to know the anatomy, know the clinical valgus stress X-ray, but also to use stress X-rays to help us in judging how much gapping they have. And if they gap in extension, so anybody in the room that sees an athlete, if you have them gap in extension with valgus when they initially present, send them to rehab, but also tell them there's probably almost a 100% chance that they're going to require surgery. So send them to rehab like Claire talked about, get their motion back. Once they quiet down, obtain stress X-rays, which you'll find out they usually almost never heal, and then we can look at reconstructions with the ACL. There's good data out there biomechanically to show that it does overload an ACL graft when you have an MCL there. And also there's good clinical data from Sweden in their registry, which showed that there was a significantly increased rate of failure when the MCL was not performed. What about the anterolateral complex? Andy Giesland is going to talk about this. We've done some anatomic studies on this. The iliotibial band is the most important structure to cause the pivot shift outside of the ACL. And that's been shown biomechanically. It's not the anterolateral ligament. There's systematic reviews that show that now. But the anterolateral ligament's also important because if we reconstruct it, it can effectively do the same thing as a LET. And this is where the anatomy is. It's all in the same area. The biomechanics show that they're both important. We have to just be careful that we don't over-constrain the joint by making it too tight. And the clinical studies show that when you use a hamstring graft, that clinically it does decrease the re-rupture rate and also the clinical failure rate when you add a LET to your ACL hamstring reconstruction. What about ramp tears? So ramp tears are just a term that we use, but it was coined that way because the way the meniscus attaches to the capsule posteriorly on the medial side, it looks like a ramp. So that's why it's called a ramp tear. And there's a low sensitivity for MRI scans. If there's a bone bruise present, and I just read a paper that shows if there's some medial striations in the front part of the medial femoral condyle, there's also a high risk of ramp tears. But we have to look for those in every case because in a lot of cases we'll go back and probe the meniscus and it looks pretty normal. You have to go through the notch and look in the back and you can see there's a huge meniscal capsular separation here. And that's going to overstress the ACL reconstruction and is a high risk of a bucket handle tear further down the line if we don't address it. And our biomechanical studies have shown that it causes the ACL graft to become stressed, both in its function anteriorly as well as with rotation. So you have to do a repair of these ramp tears. Our clinical outcomes, we found out they're almost present in 20% of the time. So there's not a significant difference between repairing them and ones that don't have a ramp tear. So we want to make sure, and for everybody in the room, once again, if you have a 3+ Lachman's test, it's highly likely it's something else. So that's what we were finding out clinically, is that when there was a grade 3 Lachman, 44% of the time it was a ramp tear, and only 6% of the time it was without a ramp tear. What about lateral meniscus root tears? So they're pretty common. And 10 years ago, a lot of us didn't recognize these, and now we're finding that they're present in probably 1 out of 8 to 1 out of 7 ACLs that need surgery. It's even higher in revision cases. We published 28%, and others have published in the 20% also. So it's probably a significant risk factor for having an ACL fail if we don't address it. And it's often missed on MRI. So it has to be a clinical suspicion. 3+ Lachman, 3+ pivot can also be a lateral meniscus root tear, and the MRI may miss it. It's important to understand the anatomy. If we look at the anterior root, it overlaps with the ACL. So if our guide pins, when we ream our reconstructions, drift a little lateral, we can detach the lateral meniscus, and our Japanese colleagues have showed it leads to extrusion. And then the posterior root is really close to the lateral eminence, so it doesn't sit as far posteriorly as the medial root. And we have to recognize that when we do the repairs and don't repair it too posteriorly. There's some important reasons why we need to fix them. Number one is it prevents arthritis. And in my clinical practice, where I see a lot of revisions, I'll see a lot of untreated lateral roots with lateral compartment arthritis in young patients. So we have to be better at making sure that we don't miss these so we prevent arthritis. Another is it'll cause a 3+ Lachman. And third reason, it causes that explosive pivot. So we shouldn't be adding in an anterolateral ligament reconstruction or an LET to address the explosive pivot without making sure that we're not fixing something else that's causing it in the first place. So when we do see these type of pivot shifts, this is a patient that had an ACL tear with just a lateral root with it. You can see the difference in the anterolateral rotation that occurs with these explosive pivots. It's important to identify at the time of surgery. So this is one of my professional athletes. I thought he had a root tear looking at the MRI. My colleagues at HSS that were reading the MRI said it was normal, but you just have to look at these a lot when you're treating ACLs to make sure that you know that a little bit of whiteness under the root attachment may mean there's a tear there. And we like to do transtibial repairs as the gold standard here to treat these. Another factor is that you cannot use the ACL tunnel to pull the root down. You can see them probing between the root attachment and the ACL tunnel. You can't pull these down the tunnel unless your tunnel is way too posterior because it's not anatomic. You won't pull it back in the correct position. Just to get to the summary part here, partial lateral meniscectomies do cause an ACL to be overstressed. So if somebody's had a previous partial lateral meniscectomy previously, it'll affect the pivot shift. So we may have to look at adding some type of anterolateral complex surgery or a lateral meniscal transplant. And the same thing with a medial meniscus. If you had a medial meniscectomy, you have to worry about it's going to overload the graft. So you may have to also look at adding in a LET with it or a medial meniscal transplantation. So in conclusions, try to get it right the first time. I know we've heard some information about, using rehabilitation for these patients, but we have to make sure we're choosing the right patients for rehabilitation. If they have meniscal pathology or collateral ligaments, they're probably not going to do very well. And we want to get those treated correctly the first time so that the ACL reconstruction graft works. And making sure we have a thorough workup on every patient is the best way to optimize your outcomes. Thank you.
I'm going to keep us moving along for time. Hold your questions about diagnosing and managing ACL injuries. We will have time for some discussion and questions a little bit later on ahead of the coffee break. So let's keep moving. We're going to start to talk about anterolateral ligament injuries now. Dr. Andrew Geeslin is joining us again, continuing the US theme. He is an orthopaedic surgeon, orthopaedic sports medicine specialist, and also does research in complex knee injuries. Thanks, Andrew.
Thank you. I'm a little bit nervous with Andy Williams in the front row when I use the word anterolateral ligament, so I'll be careful here. But the question that Ian asked me to talk about is it important? So you showed an infographic. This is another type of infographic. We're trying to help people understand whether this is an important structure and what this region of the knee is all about. So I'm going to go through the evolution, clinical studies, and some cases. So evolution. Look at the anterolateral ligament, do a PubMed search, and you don't see a lot of information on this topic until the paper in 2013 that a lot of us in the room may be familiar with by Stephen Klaus, and you see a pretty big explosion in the interest in this topic. And this is that paper. It shows the anatomy. We understand the anatomy of this to be a little bit different than this article showed, but it's still an important idea that there is tissue on the anterolateral part of the knee, whether to call it the ALL or the capsule, but a tissue that's important in this part of the knee for rotational stability. But this isn't new, even though it was largely interpreted as being new. We know that this was discussed over 100 years ago, and again 65 years ago and 40 years ago, so it's not brand new information. But at that time, if you did a Google search, this is 10 years ago, you had all these popular press articles describing this new ligament of the knee, and so it generated a lot of interest in both the orthopedic world as well as the lay media. And Rob showed this slide. It goes into a lot of detail, and you see a lot of overlap. And sometimes we get tunnel vision. You say, well, it's an FCL tear or a posterolateral corner injury or an anterolateral complex injury, but these structures are all very close to each other. And you can see the ALL that's outlined here, and it's really a capsular type structure, and the lateral capsule splits and goes superficial and deep to the fibuloclavicular ligament. But all these structures are overlapping. If you've done any dissections here, you can attest to that. So the question is it important? Well, that's controversial. You can see a series of articles in 2016, 17, 18, where there's a kind of a point-counterpoint, and it generates a lot of interest in the orthopedic world when you bring up anterolateral ligament. Because of that, Al Getgood and Charlie Brown, we saw some of Charlie's nice dissections. They convened a meeting in the Anterolateral Consensus Group. And that was 6 years ago in the UK. And we tried to come up with a series of recommendations on what we think the current understanding is and where future work needs to be done and what are potential indications for adding an anterolateral complex procedure, whether that's an LET or an anterolateral ligament reconstruction. So we had people from both sides of the aisle that were giving talks at this meeting. I'm not going to go through all of the individual points, but I'd encourage you to look at this article. And I think a lot of what we've said at that time still holds true, even though there's been a lot of further expansion of the literature on this topic. So can you diagnose ALL or a capsular or a LET or a capsule osseous or Kaplan fiber, all these structures that are overlapping, can you diagnose these on imaging? Well, I would argue that you can, but you got to be careful and not have too much bias when you're looking at it and assume that the structure is injured just because there's some edema. And we've done some MRI studies looking at it in over 100 patients, and you see that there is definitely edema along the Kaplan fibers and anterolateral complex in more severe injuries. And as Rob said, you can't just assume that because they have an ACL tear, it's just an ACL tear. You got to look at everything. So this is a patient with an MRI showing an ACL tear, MCL tear. There's edema throughout the anterolateral complex of the knee. There's a really ugly posterior lateral meniscal tear, an oblique radial tear. So scrutinize your MRI, look at it with your colleagues, and interpret this on the MRI, but also your physical exam and your diagnostic scope. So again, can it be diagnosed? Yes, I think you can look at an MRI to help you understand that, but you also have to have your physical exam, and Rob showed a video of this, and this is a pivot shift on an EUA. Pivot shift's not very sensitive in the office, but it's much more sensitive with an anesthetized patient, and here's a Lockman. So that's not just a simple ACL tear. There's something more going on there. And I'm not going to go through all the detailed biomechanical studies, but many of these are written by people in this room that have contributed greatly to this topic. And these are more the recent studies, but we were talking about this, or not we, because I was in elementary school in the 90s, but the topic was being discussed a long time ago. It's not just in the last 7 to 10 years. So people have looked at the native biomechanics as well as the biomechanics of reconstruction techniques. And I'll go back to that infographic I showed, and I'm not going to hit every single point on here, but we have to understand the anatomy is relatively complex. You need to look at physical exam. Rob talked about slope. The next talk is going to talk about slope. And you have to consider all these factors when you're discussing whether you want to add a lateral extraarticular procedure in your ACL injured patient. And I'm just going to highlight these two different techniques, ALL reconstruction or the lateral extraarticular tenodesis. And we did a systematic review looking at different ALL reconstruction techniques. Back in 2017, there wasn't a lot of data on it. There was several technique articles, but not much clinical data. And Rob and his group also looked at the LET procedure and biomechanical results. And this was looking at some older data, and what they found is that there's reduced internal rotation, or the term over-constraint, which is a controversial term, but reduced internal rotation compared to the native state. But it also protected the ACL graft. If you did an LET, you'd reduce the force in the ACL graft. But this is a study from 2017. I think it's an important study because it helps us understand what an ALL reconstruction can do in a group of athletes. And interestingly, they have a much higher failure rate than I experienced and I think is published in the States with the BTB graft, 17%. That's much higher than is typically reported. But when you added the hamstring or when you add an ALL reconstruction, the hamstring had dropped it from 11% to 4%. And interestingly, with the LET, this is Al Getgood's study with the stability trial, and they're enrolling for stability 2 now with over 500 patients, but they have a lot more to go. They found the 11% down to 4% as well. So adding a lateral extra-articular procedure, whether it's an ALL reconstruction or a tenodesis, can substantially reduce the re-tear rate. And our goal for treating athletes is to prevent additional surgery. And Rob reviewed a lot of indications for treating different structures in the knee. I think you've got to have this in your toolbox. It's important to understand it. Whether you're an ALL surgeon or an LET surgeon, I think there's going to be continued debate over the next decade to decide which is the right procedure or are both the right procedure. My personal preference is for the tenodesis. I haven't done ALL reconstruction in my patients. However, I think both may have a role. So in summary, the anatomy and biomechanics definitely demonstrate a role for addressing the tissue in this portion of the knee. The clinical studies have promising early results, but we don't have long-term randomized trials. And I think we need to have continued investigation to clarify both the indications, and they're expanding pretty dramatically for this procedure, but we also have to think about the contraindications and who not to do the procedure in. Thank you.
Thanks, Andy. So next up is Nick Kennedy, who did his orthopedic training at the Mayo Clinic, and more recently in his sports medicine training in Minnesota. So thanks, Nick, who's going to continue the theme of looking beyond just the ACL and talk about alignment.
Yep. So we'll pivot a little bit from Andy's talk, focused mostly on soft tissue, and talk osseous, but thanks so much for the opportunity to speak today. No disclosures relevant to this talk. So when you think about it, really, foundation is the key to everything, right? Key to a good relationship, key to how to build a home. And in orthopedics, we think about alignment being that foundation. So before you go addressing soft tissue pathologies, you should really consider the underlying osseous alignment, so you don't go building a house on the side of a hill, right? So we're going to kind of throw a lot at you here for a second. We're going to go through the history, anatomy, and biomechanics of malalignment and then osseous procedures, the clinical evaluation, or how you can work this patient up in your clinic, the outcomes associated with both when you don't address the malalignment as well as when you do some sort of osseous correction, and then some tips and tricks in terms of commonly performed osteotomies. So from a history, even though Americans would have you believe osteotomy was invented in the last 5 years, obviously Europeans are well versed in this. It's been going on for some time. In fact, in 1880, Sir William McEwen had already performed over 1,800 osteotomies and had published his outcome demonstrating safety and efficacy, and that's 140 years ago. So what is natal coronal alignment? I think it's important to start there. This is a relatively complex question, but simplistically, it's when mechanical access falls in between the lateral and medial tibial spines. So varus malalignment is the most common malalignment seen. In terms of an ACL cohort specifically, internally we've looked and found that about 50% of the time your ACL cohort is in neutral alignment, about 35% of the time varus, and 15% valgus. What about sagittal alignment? Again, a lot of disagreement here, but I think fairly accepted that 6 to 9 degrees is the average posterior tibial slope, depending on whether you're measuring medial or lateral. Females tend to have a higher slope than males, and then it's very ethnicity dependent. So again, the Middle East, like Charlie's population, for example, very high slope. African population, very high slope. And then, of course, an ACL injured population tends to have a higher slope. Again, internally, we found our data to be about 11 degrees. So why do we care? What effect does this have on the biomechanics? So there's an abundance of biomechanical literature out there. I won't bore you with all of it, but basically, valgus, we know, increases ACL graft forces as well as dynamic valgus angles. So more importantly, biomechanically, when you correct the osseous malalignment, it's actually more powerful than just soft tissue ligamentous reconstruction. Varus similarly leads to increased graft forces, and perhaps more importantly in that instance, when you have a varus deformity in the setting of an ACL deficiency, that changes your whole tibiofemoral gait, right? That leads to a varus thrust gait. And then increased posterior tibial slope, again, there's an abundance of literature out there, particularly in the last 10 years, but now we have a good understanding that it's pretty much a linear relationship. You increase slope, you increase anterior tibial translation, you get increased ACL graft forces. So how to work it up? Commonly, a lot of people are still just doing a standard AP. We have a good literature out there, including Dr. LaPrad's work, that demonstrates that's not an accurate representation of the alignment. Long leg films are your gold standard. Ensure that you have some sort of a protocol with your radiation, your radiology teams, that they know how to do it. Make sure that patients are equal weight bearing through each extremity. If you're offloading one extremity versus the other, it can completely alter what the alignment looks like. So how to measure, again, this could be, our deformity colleagues could tell you this could be a multiple hour talk in and of itself, but simplistically, think mechanical axis deviation to determine whether it's valgus or varus, and then think the lateral distal femoral angle and the medial proximal tibial angle to determine what's the culprit, the tibia or the femur, okay? General rules, people assume that a varus alignment, malalignment would be due to tibia and a valgus due to the femur, but that is not always the case, and we should not assume, particularly if you're going to undergo this procedure, okay? Understand the center of rotation of angulation, or where is the key point in terms of that deformity. So internally, we looked, when you have a varus mechanical malalignment based on mechanical axis deviation, only about 78% of the time is the tibia the culprit, or it's due to some tibia varus. Even more telling is valgus. Only about 47% of the time when you find long leg valgus is it actually due to a femoral problem. So almost 40% of the time it's a tibial-based problem. So you got to know the bone that is pathologic to address it. You can't go addressing a tibia with a femoral problem, okay? So what happens when we assume? You get joint line obliquity. I think this is important to just touch on. Again, it's somewhat of a higher level discussion, but if you have mechanical axis that's in varus, your assumption is it's due to the tibia and you perform a medial opening wedge osteotomy, what you're going to do is you're going to induce pathologic amounts of valgus, which is going to lead to this obliquity, okay? Obliquity can actually increase shear forces and compressive loads to an extent beyond what their initial coronal malalignment was causing. So you've taken a bad problem and you've made it worse. So you have to understand all three angles are key in terms of addressing these problems. Sagittal alignment, again, can get quite complex. The two that we use as workhorses in clinic are A and C here, which is the proximal anatomic axis, and then the long leg mechanical axis. A lot of the data, particularly in terms of like what Andy was talking about 12 degrees, considering LET or considering an osseous procedure, they're mostly talking about A, so the proximal anatomic axis. These are not uniform. It will change depending on where you measure this angle, so understand what your indications are for surgery is based on a certain measurement, okay? Lateral and medial posterior tibial slope have also been used interchangeably. Usually lateral is more commonly noted. What else can a lateral tell you, specifically in regards to slope? It can tell you anterior tibial translation, right? I think this x-ray is really key. So the x-rays on the left demonstrate actually a normal patient, okay, no previous ACL, no injury whatsoever, and they've got 9.5 millimeters of anterior tibial translation. That's purely due to their slope, okay? When they then have a complete ACL injury, that translation only increases about 3 to 5 millimeters, which is what the data would say. So the majority of that anterior subluxation of the tibial escape is actually due to the osseous morphology. That's key to know in terms of which patients should be addressed potentially with an osseous procedure. This slide's very busy. Don't get lost in it. Basically, it's that an osteotomy is a procedure for some people. It's not the procedure for everyone, okay? So understanding who's a good candidate. Primary versus revision setting. If you're going to do a revision, are you already two-staging them due to tunnel lysis? Well, then an osteotomy doesn't add much for you, right? Understanding the severity of the malalignment. Do they have instability just in day-to-day function, or is it instability only with high-level activities? And then understanding patient goals, as always. So what does the data say? Again, we'll kind of rip through this. So leaving high posterior tibial slope, we know increases the rate of failure both in the primary and revision setting by as much as 5x. Coronal malalignment, we don't really have a good understanding of how that affects outcomes in the ACL literature, okay? We know biomechanically it should make a difference, but there's no clinical data that demonstrates that for sure varus or valgus malalignment leads to increased failure, okay? When you correct the slope, or correct, with HTOs, we have a bunch of safety and efficacy data, low risk profile with these surgeries. And then in terms of corrective slope specifically, we know that decreases the revision risk in the ACL population. These patients do quite well when performed well. And then debunking this theory. So commonly, particularly at American courses, we discuss how we would never perform an osseous correction for a high-level athlete. Like that seems like malpractice. We'll do a multi-ligamentous reconstruction. We'll put an OCA in there, but we won't address the underlying osseous pathology. To me, to not do a bony procedure makes no sense. For the most part, when done well, bones heal. And I think they're basing a lot of this on historic literature, which was a different patient population. The old historic osteotomy literature, remember, is in patients over the 50 for the most part. So Get Good has demonstrated fairly definitively these patients return to sport at a high level, north of 85%. Other things to consider if you determine this patient is a good osteotomy candidate, remember, be a doctor before a surgeon. Things like Ehlers-Danlos can creep up on you. You'd hate to have a non-union at 3 to 6 months because you didn't take the time to just do a basic workup. Understanding overall metabolic health, perhaps with an albumin level or something to say how healthy is this patient? Can they heal a fracture? understanding patellar height so you don't induce some Baja or Alta, so when do you need to do a TTO, and then recurvatum. If a patient has baseline recurvatum before you've done an osseous procedure, so it's soft tissue based, and then you do a closing wedge osteotomy, you can induce pathologic amounts of recurvatum, so that needs to be on your radar. So really quickly, just some tips and tricks in terms of common osteotomies we perform. So localize the incision for a medial opening wedge, somewhere in between the anterior and the posterior cortices on the medial face. Remember, this is not a small, sexy incision. This is a big incision so you can see, so you can be safe. Subperiosteal dissection. Retractors in the front and back, so you're in that subperiosteal plane, so you should be protecting the neurovascular structures. You should aim for the fibular head, the center of the fibular head. If you aim within 2 centimeters of the joint line, your risk of iatrogenic fracture into the joint is significantly elevated. Slow controlled opening, and then ensure appropriate hardware position. Lateral opening wedge is really a lot of the same stuff. Remember, when you do your IT band split for a distal femoral osteotomy, it should be on the posterior border. It just easily, or it helps to ease the moving the extensor mechanism anteriorly over the femur. Again, subperiosteal dissection, C to be safe, aim for the epicondylar region. Last thing we're going to go through here is how Dr. Laprade performs a closing wedge osteotomy. So subperiosteal dissections laterally and medially on either side of the tendon. Laterally working towards but not involving the proximal tib-fib joint, medially all the way around the corner. Again, you want to see in these procedures. Get your retractors in there. Then what we do is freehand, we place 2 pins perpendicular to the tibia at the level of the superior border of the tibial tubercle. Confirm this on fluoroscopy. Mark out the size of your wedge, usually somewhere between 6 and 9 millimeters. And then 2 pins are placed at an angle down towards the inferior pins, meeting at the far cortex. You can then perform the osteotomy with a combination of curette, osteotome, and saw. Save that bone for packing tunnel lysis, or if there's areas you want to pack your osteotomy at the end. You can then finish the osteotomy again with a small osteotome, so it's controlled. Pack the graft in the tunnels, perform a slow, controlled extension moment, and then fix with either staples or plate in the front. Of note, there's not a fantastic plate on the market right now to place on the front of a tibia. A lot of people will use a medial-based plate, so our preference is staples. So in summary, just understand that alignment affects ACL biomechanics and its outcomes. Now remember that everything begins the foundation of alignment, so that should be worked up in all your ACL patients so you at least have an understanding. An osteotomy is for someone, it's not for everyone, so you got to weigh concomitant risk factors. And then lastly, we've been doing these since the 1800s with, they're a relatively safe procedure. It's not something you should be afraid of if you have a replicable technique and you have a good staff to do it with. Thank you so much.
Meniscus, you've heard just how important meniscus injuries are. You'll know this, and we're fortunate to have Tim Spalding joining us from Cleveland Clinic in London and the Warwickshire Nuffield Hospital. Tim operates a lot on ACL injuries, on intra-articular knee injuries more broadly. So Tim, over to you to share ideas and thoughts on radial ramp and root tears of the meniscus.
Thank you very much. So this is now going back to focus on these 3 areas and give a bit more detail on that and add to what's been said before. And it's quite interesting that these things were just not really around when I was doing my fellowship. We didn't know how to fix them. We didn't really recognize what they were, how important they were. So I want to cover that, going back on the importance and then some of the surgical aspects for these three areas, the radial tear, the root, and then the ramp lesion. So I have no specific conflicts of interest for this talk. So starting off with the root tears, right, so these essentially defunction the whole meniscus because you've lost your attachment, so then the cushioning effect of the meniscus is simply not there, and you can get this rapid deterioration in the joint surface. So we've heard how important they are then to fix. Rob has then classified these, and the common one is the type 2 there, and they're defined essentially as within 10 millimeters of the root to then bring it back into place and fix it back down. But that's our common root tear that we're going to be fixing. In general, the medial meniscal root tears are associated with joint surface damage, and they're in the more degenerative and the older patient, and then the lateral meniscal root tears associated in the younger patient and traumatic associated with ACL tears, much more likely in the ACL deficient knee. And then unfortunately there are still the iatrogenic damaged tears associated with tunnel drilling, as we saw on the anatomy pictures from Rob. Why we should do it? Well, it's very clear in the data that if you do non-operative management of symptomatic medial meniscus root tears, then we have this high conversion rate to knee replacement in the first 5 years. And there are several series that will show that. So it's very important on the medial side and also on the lateral side. Now, the influence on the lateral side is the meniscofemoral ligaments that can then give support to that meniscus, holding it as it's cushioning. And it's really when you lose both there on the bottom right here, then you see the increase in the pressure and the contact force on the joint surface. We know that if you lose the root, then you're going to get increased rotational instability of the knee because that meniscus is no longer holding it in place. So the comments were then mentioned in the talk with Rob that essentially if you've got no lateral meniscus root and no meniscofemoral ligament and the ACL, then we see the increased rotation. And so we should be thinking about that, this explosive pivot, the 3+ pivot, or the 2 to 3+ Lachman. There must be something else going on in there, so we have to look for it. So we may hear in the older patient the pop, but the ACL is fine. The meniscus may feel tender, and we've got to actively look for it on the MRI and then probe the meniscus to identify it. One other point to mention is that a big cause of when we see the osteonecrosis type, the bone marrow edema type problem, there may well be a root tear that has led to this sudden overload on the femoral condyle, and therefore that's something to consider. Think about the root. And the diagnosis is this ghost sign on the MRI. Hopefully you can see that, but just in a bit more detail on that. If we take our normal MRI on the coronal section and we're following that through, you can see the meniscus in that position, and as we're going towards the back of the knee, then the meniscus root is intact, and we can trace that down and we can see it sitting there in the right place. But then if we take a patient with a root tear, then we can follow along in that same thing. The meniscus is extruded, and we work towards the back of the knee, and then you can see that gap where the root is just simply not attached. The meniscus is tenting the MCL, giving pain on that medial side. So that's the root tear that we're looking for, this characteristic gap at the back. And then on the sagittal view, we're following along towards the midline. The meniscus is there, all looks very good, and then suddenly it's disappeared. That's the ghost sign where it's gone. And then often on the next slice, it's back again because you're back down to the root. So that's spotting that ghost sign. So repair, this is the transtibial root repair, then up through the tibia and a tape suture around the meniscus to pull it back down. The key being preparing the meniscal bed, mobilizing the meniscus, and then being non-weight bearing for 6 weeks afterwards. There are now special root guides out in this. Both Rob and I were involved in some of the shaping the design on this particular root guide for Smith & Nephew, and there are other different companies that make it easier now to reach into the posterior part of the knee. So just going through some of the technique bits, we can see how the root is lifted up here, and then we need to mobilize it, make sure it will come back to that place, and drilling our tibial tunnel up in that right place. So we're got a curette down the base, use a guide, drill the wire initially, and then over drill it, and we're passing a loop suture up through that tibial tunnel, and that is then retrieved out through the portal. So that's out the way, and prefer to do it that way around. Now, putting in the suture has to be in the right place, and this first suture is not in the right place, so we need to reposition it to get a good bite on the meniscus, to draw the root back into place. So you need to be in the body of the meniscus, not just right at the tip. 2 sutures go through, and there are 2 or 3 of these devices, these suture passing devices, to bring the tape through. And this is using a simple suture. And then we pull those out through the outside. And then on the outer side of the knee, we're passing the tape through that loop, and then draw that loop and the tape down through the tibial tunnel to bring the root back into that prepared bed to put it in place. So that draws it back in and then holds the meniscus, reconstituting that the hoop forces on the meniscus. And then just on the outside, we're tying those sutures over a button to the 2 tapes. Pull one down first tight, snug them down to get a good hold. I prefer the 2 simple sutures rather than a cinch suture, and that's been shown in this work, the 2 simple sutures having less displacement, which is why I use that rather than the cinch suture, which then crushes down the meniscus and we'll get this creep. on some outcome data, right, so it's not only the mid-sagittal plane where we're going to get extrusion. So this is flexion at 10 degrees, but it's then at 90 degrees we see this pushing back of the meniscus over the back of the tibia. And by reconnecting the root, then we've reduced that. So it's not only just in the obvious mid-sagittal plane, but it's on that posteromedial area as the benefit of reconstituting the root. There are several, this is just a selection of some very recent papers making the point lateral seems to do better than medial, but they're different age groups. The medial root here, the results just recently published, only a 1% rate of knee replacement and a 3% failure rate. Measuring extrusion is an interesting topic, and it does depend on the techniques of doing it, but on average it's 3 millimeters after the procedure. And then the evidence is growing that this may progress or slow down progression of arthritis, but we really need a randomized trial to prove that over the long term. And then in another paper, more clear that at minimum of 4-year follow-ups, then there's a lower progression to arthritis in that group. So the points we're trying to make from here, right? We need good joint surface still remaining. If there's already down to bare bone, that meniscus is not going to hold. The meniscus needs to be able to be reduced back into place. And then the risk factors for getting a poor result, advanced arthritis, already bare bone. And then we're still going to see some extrusion afterwards, but certainly it's clear less seems to be better. So better techniques to try and hold the meniscus back in place. And these are the two latest reviews on the topic for further reading. So let me move on to radial tears. So radial tears, again, effectively defunction the meniscus. Here's a guy who has a meniscus tear, treated elsewhere with resection of that meniscus, and then he comes to me for meniscus transplant, and then just within a year or so he's got a rapid deterioration of the joint surface because effectively the whole meniscus has been defunctioned by not treating it. So these then can be repaired, and we should recognize these on MRI, the truncated triangle sign or the cleft sign. Right, so that's a gap here in the meniscus. Important to recognize that and then to look for it. So then at surgery, we can define the pattern. There we see this radial tear. So the meniscus can then be is being squeezed out to the side and front to back, so it's not providing that cushioning. And the fixation technique has been this tie grip or hashtag suture with two sutures that act to stop the main tape sutures from pulling out. And then that's brought the edges together. And with that, we then in various series can get a good healing rate for this. So on the technique, the first part is to pass in the vertical sutures. So these are the ripstop sutures to stop the neck sutures then from pulling through. And these are sutures passed from inside out, so it results in a small incision on the outside to tie the sutures out on the capsule outside once you're bringing the two ends together. If they're very retracted, then we may need a first suture to be able to pull the two ends together. So then we're putting in 3 sutures on the top, and then again try and put 2 or 3 sutures on the bottom of the meniscus to hold it together. And in that way, with that ripstop suture, we can bring the edges together. So this is a successful technique for repairing the very important radial tear. Okay, so now the last bit on ramp lesions. Again, not around years ago, not recognized their importance, and I'm just trying to put some not sense to this, but some practical aspects to it. We need to look for them, and you have to probe the meniscus to find. There are other diagnoses, they were known as a hidden lesion because they're not seen. But we understand that they're important because they don't hold the meniscus and therefore the femoral condyle in place. So we're defining it as this peripheral separation of the posterior third of the meniscus, near or at that meniscocapsular junction. And it's usually then associated with an ACL injury. So the points I want to make, they are present, various series, 9 to 30%. MRI not so good at diagnosing it. And the result is this increased anterior movement and increased rotation to get the increased pivot shift. So the management at the moment, however, is very much based on some very low evidence level studies. And there's a difference between some stable lesions and some unstable lesions. So just trying to draw that together. And then we have an argument of whether we can fix it all inside or a complex posteromedial approach. This is a series of papers that put that together as the incidence of seeing the ramp lesion between this 9 and 30%. MRI won't necessarily pick it up, and we need to put the needle in to then basically to be able to probe the posterior and look through the notch, put the needle in, pull on the meniscus, and define that area if there's a separation on the meniscus to the posterior capsule. One of the theories why this happens is because as the ACL ruptures with the tibia going forwards, then the semimembranosus tendon and its insertion on the posterior capsule pulls that back. And this was described way back 93. And you can see the semimembranosus extension attaching to the back of the capsule to split this area. So what we see then, if there's no attachment here, then there's more movement. The meniscus as a ramp to the femur is able to move more, and you get this anterior tibial translation. And you see it on this diagram here, that then therefore the tibia can come more forwards, and we get this increased rotation. So that's their importance. This ramp is not holding in the right place. So the results then, we're seeing this injury, and this is some of Rob's work again, the injury, and it's the meniscotibial ligament here that's the important bit that holds the meniscus back in its right place. So when you come to fix it, we've got to fix that whole area to reduce it. So here's a concept for management and the stable or the unstable meniscus. If it's picked up, then we can then probe that area. And this puts together a whole bunch of papers in the last couple of years to try and analyze this, because the whole data is sometimes a bit obscure. So the first two types on the superior surface, fine, they are considered stable lesions and could either be left alone, trephine them, or do an all-inside technique using one of the devices to repair those back. But it's picking up the unstable tears that are on the underside, inferior, the hidden lesions that allow the meniscus then to move forwards and not control the knee, or the complete tears. So if these are the unstable tears, then these should be fixed to reduce that anterior movement and load on the ACL. If using an all-inside device, it should be on the undersurface to fix back meniscus on the meniscotibial ligament. Or if we're doing the posteromedial approach, then we need to capture the whole meniscus to suture it back to here, to get round and fix this back onto that meniscotibial ligament. And that's one of the techniques, putting sutures in through the posterior part to fix that meniscus back. So the message here for the ramp lesions, now we have to look for them. We've got to probe through the notch, either a hook from posterior or a probe from anterior to see this gap between the meniscus. Look for the bone bruising on the MRI. I didn't emphasize that enough, that if there's bone bruising, that's a real clue, the posterior part of the tibia. Decide if they're stable or unstable, and then fix the unstable ones. And that means learning a posteromedial portal suturing technique, which is not a familiar approach to many knee surgeons. So put the three together. We need to recognize these new tears, the importance, which is now I've sort of double emphasized this here at the meeting, have a technique, and we need the kit available in the hospital ready to call on when you need it, and have your treatment algorithm. So thank you for inviting me to the meeting, and enjoy the rest of the conference.
Thanks, Tim. We're moving further and further back in the knee, so it's Rob back to tell us about PCL injuries.
So thank you. I think it's important to recognize that the surgical treatment of PCLs is important, and many of you may have seen PCL reconstructions that ended up just as unstable over time, and we were seeing that 20 years ago. So Lars and I put a lot of effort in the last 20 years at trying to improve the outcomes with PCL injuries, and that's what I'll be talking about today. Here's my disclosures, nothing relevant to PCL. So the historical problems with PCL reconstructions, first off, the outcomes for patient-reported outcomes have been a lot poorer than ACL reconstructions, and we know that in the literature. And it became obvious that many surgeons abandoned their single bundle PCL reconstruction techniques because the graft stretched out and they weren't much better. And it's important to recognize that the physiotherapy treatment of these is just as important as the surgical technique, as well as the postoperative bracing. If you put them all together, the chances of an outstanding outcome are significantly improved. So we do all of our research based on the research pyramid. With the base of the pyramid, we go back and look at quantitative anatomy studies, and then use that and do biomechanical studies in the newly defined quantitative anatomy, then looking at anatomic reconstructions and better ways to diagnose the pathology, and then hopefully the top of the pyramid validates everything until we get to that point in time. So that's what Lars and I have done for the PCL reconstructions. So the goals here are to review PCL anatomy, to help understand why it's important to do a double bundle PCL reconstruction, then look at the clinically relevant biomechanics, understand the clinical exam and stress radiographs, and then review our outcomes. So first off, the PCL is two separate bundles, and it's different than the ACL in that the posterior medial bundle is like a ribbon and it attaches on the wall, and the anterolateral bundle is almost straight up and down and attaches on the roof. So biomechanically, they're different structures, and they are far enough apart that they function separately, and it's important to recognize that when we're looking at the PCL. So the anterolateral bundle attaches on the roof, which is where most single bundle reconstructions are, and the posterior medial bundle is on the wall, and there's an average of 12.5 millimeters between them on average, so that they're far enough apart that we can have two separate, relatively robust tunnels to be able to reconstruct these. Now the PCL attachment side is a lot more compact. It's less than 9 millimeters, so we can't have two separate tunnels there. So we have to have one tunnel on the PCL to be able to address it. So when we're talking about double bundles, it's not very hard than what we do for single bundles, and it makes a huge difference in what we've been able to have for outcomes in our patients. So we went and looked at the relative biomechanics and cut either the anterolateral bundle and tested it, and cut the posterior medial bundle and then cut the whole PCL. And we found out that basically you have to have both bundles injured to be able to have a significant increase in translation. So it's really hard to have a posterior drawer that's more than 6 millimeters without having both bundles significantly injured. So a single bundle injury by itself is probably only going to increase your posterior tibial translation by 2 to 3 millimeters. And then we went in and looked at the biomechanics. We looked at performing single bundle reconstructions versus double bundle reconstructions in a robot. And a robot is like a physical therapist from hell, because it's 10 hours of testing, it goes all day long, and these are going to stretch out over time with testing if it's not put in the right spot. And what we found out is that the single bundle reconstructions, you can see them here in green, are what's basically been found in the literature over time. You end up with 4 to 5 millimeters of increased posterior tibial translation, and the double bundle PCL reconstructions were about 1 to 2 millimeters. So remember those numbers. And then we looked at tensioning. So tensioning has been historically all over the board in terms of where to tension each bundle. They can be at 90, some people put it at 45 in the literature, some are in full extension. And so Nick Kennedy worked on this, and we looked at multiple different iterations here, and we found out we had to fix the anterolateral bundle first at 90 degrees of flexion, and then straighten the knee out and fix the posterior medial bundle and extension. And if we tried to fix the posterior medial bundle in anything other than full extension, it was over-constraining it, and it would stretch out over time. And the same thing with the anterolateral bundle. You can get close to 90, but if you're tightening it at other angles, it'll also over-constrain it and cause it to stretch out. So we get good information of what positions we have to tension our double bundle PCL reconstructions. And the other thing is recognizing that this is something we need good objective data. So if you're a PCL surgeon, or if you're treating PCLs and sending them to somebody else, you should be getting PCL stress radiographs on everybody beforehand and afterwards to see how your outcomes are. And the numbers are, if you have roughly 8 to 10 or 11 millimeters, it's probably an isolated PCL. If you have 12 millimeters or more, it's likely to be a PCL with a posterolateral corner, a posteromedial corner, or the new information we figured out in the last few years is a difference in slope. And so slope alone can cause increases in translation, even in patients that don't have a PCL tear. So recognize that also, that slope is an important factor to take into consideration. So we looked at our patients that had PCL tears, and we found out that most of them had a flat slope. So when people fell down on a flexed knee, they're not tearing their PCL if they have an increase in slope. But if they do have a flat slope, so less than 6 millimeters is the definition, then there's a much higher risk. And you can see with the non-contact versus a contact PCLs in our patients, the same numbers fit there. So ACLs, higher slopes, PCLs, lower slopes. So there's important information for the osseous anatomy in evaluating these. And we also know that our German friends have published that if you do have a single bundle PCL reconstruction, there's a higher risk it'll stretch out over time. We found out that our double bundle grafts are having less loads over time, and that magic number for slope was about 8 degrees to unload the PCL. So as you increase your slope, your PCL gets unloaded. When we looked at our double bundle reconstructions, they're not stretching out over time compared to the single bundle reconstructions historically in the literature. So that's a definite indication to look at performing a double bundle PCL reconstruction is in a patient with a flatter slope, but in 100 consecutive patients that we had, almost all of them were flat slopes. So I'll go through the double bundle technique. It's not hard. It has 2 closed socket femoral tunnels and 1 tibial tunnel. And it's important that we validate that our tibial tunnel is in the correct position with x-rays. So first off, the anatomy, it's actually incredible that it's so simple because the anterolateral bundle goes from the bundle ridge to the trochlear point. And if you look at the medial arch point there, you can see that that's the roof. So we know that the anterolateral bundle is on the roof, and then the posterior medial bundle is on the wall. For the tibia, we are making sure that we have one tunnel. We use a 12 millimeter tunnel. It's centered at the bundle ridge where the PCL attaches. And we always try to get an intraoperative x-ray because we've seen a lot of iatrogenic failed PCL reconstructions that take out the medial meniscal root. So you don't want to be that person. So we'll use a large curette posteriorly. You can see I'm finishing my reaming by hand. We should use an acorn reamer because a smoothbore reamer can inadvertently go out the back part of the tibia. So with an acorn reamer and doing it by hand, you can walk over the back if you're getting a little posterior on the cortex. And remember, if it's too anterior, there's a high risk of having an iatrogenic root tear. And then we'll pass the grafts into the femur. So we've created the tunnels endoscopically with the anterior medial and posterolateral bundles. And the posterior medial bundle is fixed first. We place in a bioabsorbable screw, and then the anterolateral bundle is placed second with a bone plug. So I use allografts here. We use an Achilles graft with a bone plug in the femur, and then a tibialis anterior graft with a soft tissue screw because it's a soft tissue graft in the tibia. So you can see it's relatively easy for us as surgeons because we've done ACLs in the back of the knee and the PCLs in the front of the knee, so it's easy to pass these grafts and fix them. Now the next point is where we're able to make this a lot easier in that we use a smoother up the tibia and pull the end of the smoother out the lateral portal, then put the sutures in the ends of the grafts in the smoother, and then pull it down the tibia. And it usually takes us about 5 seconds to be able to do it. It's quick and efficient, and when I was a fellow doing these with some experts, it once took us 2 hours to pass the grafts alone. I promised myself I was not going to let that happen to me. So we figured out a way to make it 5 seconds and easily passable. And then we look inside the joint and make sure that the grafts aren't bunched up. There's something called the ACL slack sign, where when you have a PCL deficiency, the ACL slips back. So we make sure the slack sign is eliminated by pulling on the grafts. And then we'll fix them on the tibias. So we'll, just like we found biomechanically, we'll fix the anterolateral bundle at 90 degrees of flexion and restore the tibial femoral step off with a screw and washer. And then we'll straighten the knee out and fix the posterior medial bundle in full extension. Rehab is essential for PCLs, probably more important than for ACLs. So we start with physio starting on day 1. I see all my patients after surgery, no matter what they have, on day 1, but for PCLs, we emphasize they have prone knee flexion to negate the effects of gravity. Start them on quad activation. We're trying to get them to 90 degrees of flexion. We'll place them into a PCL dynamic rebound brace that will fit as soon as their incisions allow. We try to put them in the brace ahead of time so they know how to manage the brace, and then we'll put it in afterwards. So we know it's safe with our biomechanical data and our follow-up clinical data that they can be in this brace and moving their knee, sitting in a chair after a PCL reconstruction within a few days. At week 6, we'll have full weight bearing, starting leg presses and progression, but it's a slow progression. PCLs have to go slow. At 6 months, we'll get the PCL stress x-rays again, and if those look good, we'll start to wean them out of their dynamic bracing and progress the activities with the goal of getting most of our athletes back from 9 to 12 months post-operatively. I can't emphasize it enough that a dynamic brace is essential for PCLs. You can treat non-operatively acute PCL tears with a dynamic brace, and it'll restore the tibial femoral step-off. And Rolly Jakob has published good data showing that they can heal 50 to 60% of it, which may be enough. They don't need surgery. So it's important to use that. It protects against gravity-induced posterior tibial translation. So use the brace if you're going to be doing PCL reconstructions. What are our clinical outcomes? So our first paper we published in JBJS over 10 years ago, where we looked at patients. We used staples in the tibia with a less aggressive rehabilitation program. Our preoperative stress x-rays were 15 millimeters, and postoperatively, almost 3 years post-op, they were less than 1 millimeter. So remember the biomechanical data that fits with that. Then we wanted to do it with a more aggressive rehabilitation program like we've been doing recently with immediate range of motion, putting them in the brace, and we did 100 consecutive patients. We didn't have anybody that fell out. And you can see their scores are improved, but also their posterior tibial translation is a lot better than the historical data and fits with what we're seeing in our biomechanics. Within this group, we looked at our isolated ACL outcomes. So isolated to me means no other ligaments, not necessarily meniscus pathology, and compared it to the isolated double bundle PCL reconstruction without other ligaments, and our outcome scores were the same. So it's a lot different. They improve a lot in other data, but we found out that with a double bundle, you can get them back equal to the ACL outcomes. And I feel that my PCLs sometimes do better than my ACLs with the rehabilitation program that we have. So in summary, for double bundle PCL reconstructions, it restores stability better. With a well-balanced rehabilitation program, you can also get their outcomes better. It's technically simple. It's not that hard. I know a lot of people are afraid to do it, but it's not hard because all you're doing is adding one extra tunnel in front of you on the femur. We have objective information that shows that we have improved subjective and objective outcomes, which should help over time to prevent arthritis. Now we have data that show that the outcomes are equal to isolated ACL reconstruction, and it's been validated by science. Thank you very much.
Thank you, Rob. Now, we heard from Professor Lars Engebretsen yesterday in his role as leader of the IOC Medical and Science area. Today, we've got the privilege of benefiting from Lars's extensive experience as a knee surgeon, and he is going to speak about multi-ligament injuries in athletes, how we might manage them. Lars, over to you. Thank you.
Thank you. And now you can relax a little bit. Because you heard a lot of challenging cases, challenging surgeries, challenging overall, I would say, examinations and stuff like that. So now I'm going to talk about the multi-leg or the knee dislocations a little bit more. And the question I had when I show you this, have you seen this before? Anyone seen knee dislocation before? Yeah, there's a handful of you. It's unusual. I will show you how unusual it is and how to approach it. I will not go into the detailed surgical things we do. I'll just tell you a little bit about the most important part of it. This is a very typical patient. Yeah, so this is a downhill skier from Norway. He was training his proprioception on a jumping machine, and this happened. And this is a knee dislocation, an artery injury, as well as a nerve injury. So it's sort of the max. When I say knee dislocation, I mean ACL, PCL, something posteromedial or posterolateral, something on the root, in the roots, and very, very serious. People thought in the old days that this was only happening to high trauma, car accidents, falling off a cliff or something like that. I will show you that it also happens in sports, much more than it used to do. So disclosures, knee, and this is another case. This is actually this is a Norwegian team handball game. A French player came to Norway to play in Norway. And same season, he had this injury. You'll see it in slower motion. And then I'll tell you that this was actually, look at his left knee here. It's very tough sport, actually. So what did he have? He had the ultimate type of an injury, ACL, PCL, patellotendon tear, root tears as well, and posterolateral corner. This is a very, very big injury. And he came back. We did the surgery on him first. He had vascular surgery. And then 3 months later, we did the ultimate ligament surgery. And then he came back to play, and now he's back in France, playing in Paris, actually. So he did recover, which is a bit unusual when you have this kind of injuries. So historically, multi-ligament injuries are causing knee dislocations as well. I'll give you that definition in a while. Usually high energy injuries, poor outcomes, high complication rates, and many used to be overlooked in the old days because most of these are back in place when you see them in the emergency room. They're not dislocated any longer when you see them there. And this is an old from 1963, typically JBJS and major trauma. And they were saying this is very, very unusual, only in big-time car injuries and stuff like that. Now, I work in a level 1 trauma center in Oslo. We have about 3 million patients that we take care of. So therefore, we see these every year. We see about 25 to 30 of these every year, coming from, I would say, all over Norway. And this is the one that you saw, team handball. See his MRI here. You can see that the patellotendon is gone. Now we do have much more knowledge about anatomy, just like the other guys told you about here. MRI is, of course, much, much better than it was in 1963. We had nothing. Then we only had our clinical skills. Now we can do stress radiographs like Rob is showing you. And we are much more aware of the fact that these injuries actually happen, also in sports. Multi-ligament knee injuries are complete tear of either ACL or PCL plus other stuff. Clinical exam is obviously important, but if you look at this one, this is a very good illustration because in the old days, they usually ended in amputations. And it still does. I have to say that in Norway, we see 25 a year in my hospital. Actually, now and then, you end up seeing them too late, and they did not recognize the fact that the artery was gone, so they end up in an amputation. This has happened twice in my career in my hospital. So, knee dislocation versus multi-ligaments. So knee dislocation is always ACL, PCL plus. ACL, PCL plus. This is we use the Schenck classifications when we look at this, and you can read that yourself. And this is what we go by, and this is what we publish by when we tell you about the results of our surgery after these kind of injuries. And here we are not talking about non-operative surgery. So here we're talking about all kinds of operations that I will go through a little bit. Now these were the 320 first patients we had. So I came back to Norway from the US May 1st, 1996, and then I started to assemble patients like these. So when we had about 300, Gilbert Matre, who was supposed to give this lecture actually, did a follow-up on these patients. And here you can see what kind of injuries they have. All have ACL, PCL, but most of them had also medial collateral ligaments or corners, or they would have some posterolateral corners as well. These are 300 patients. These are sports patients, mostly. Here you can see what Gilbert found, that we were surprised to see that so many of them were sports-related. And most of them, because Norway is a skiing country, as you know, came from skiing in the winter, obviously, but also in the summer when people took their bikes out and they got these injuries as well in traffic injuries. And they also get all these kind of injuries in meniscus, cartilage. Unfortunately, about 20% have a peroneal nerve injury. What do I mean by that? Well, when the patient comes in, I always ask the resident, do they have a peroneal nerve injury? Did you examine him or her? And they say, I don't think so, because they can use their ankle, they can use their big toe, and they don't have much decreased sensation between first and second toe. But when I then go and examine the patient, I can see the difference between the big toe extension compared to the normal side. So I know that there is something wrong with the peroneal nerve. In about, of those 320 patients, about 25 of them had a total nerve out. That means that they have drop foot, they don't have any sensation between first and second toe. And when they're totally out, motor out and sensor out, it really does not come back. Most of the other patients, 60 of them, the nerve came back after between 3 and 6 months and became quite normal. But if it's all gone, then you have to do some tibial transfers, tendon tibial transfer technique, but I'm not going to talk about that here. So just remember this. If you have a posterolateral injury, there's high odds for neurovascular injuries, as you can read here. I think this is a very important slide for those of you who work in a trauma center and sees these kind of patients. And of course, I told you about sports, told you about motor accidents, but then also it can be a little bit overweight people. They walk their dogs and they hit a pothole. All of a sudden they have a knee dislocation, and their nerve and the artery is gone. So this is something you see in regular people being a little bit overweight. So remember that that is a possibility when you see those patients. So when you see them in the emergency room, remember to feel the pulses distally. That may not be enough, and if you are suspicious, you have to do ABC, you have to do the regular checkup, and then you end up doing a CT angiogram to make sure that the artery is intact or it's not. Of course, if it's not, you have 6 hours to fix it. If you wait more than 8 hours, it ends in amputation. So this is an emergency situation. And then if the nerve and if the artery is intact, then we usually have the patient in for about 2-3 days. We do all this other stuff. That's something that you all know about, so you can do that as well. We do an MRI to make the diagnosis final and make sure we know everything about the meniscus and cartilage and the bone. And then we do the stress x-rays. I'm not going to go into those because you already heard that. That's very easy to do. Not easy to do acutely. So the stress x-rays are for the most part, I would say, for chronic cases. Or cases like this with an injury that you will wait to do this. You need about at least 2 months before, in my opinion, before you do the stress x-rays in the acute cases. So then you assess it. You look at like Rob was telling you about, the PCL, see how much of the PCL is gone, or if everything is gone. And you do the same thing for ACL. You do the same thing medial side, lateral side, posterolateral, posteromedial, and patellar tendon. because that once in a while it will be torn as well. And then you need to prepare your people for surgery. When do we do the surgery? This is a matter of opinion. So in our hands, we do the surgery between 0 and 14 days. Within 2 weeks, we do the surgery. Most places, many times, I would say in those 3 and 20 patients, we did the surgery around 2 weeks. Because at 2 weeks, before 2 weeks, it's easy to dissect. You can find all the pathology. If you wait more than, I would say, 3-4 weeks, it's much more difficult to dissect out all your injuries. So it's much more difficult and takes much longer for your surgery. So right now, 3 weeks is defined, before 3 weeks is defined as acute surgery. I like 2 weeks, actually. So there are some studies on early or delayed surgery. And of course, if you don't have a vascular injury or a fracture or a bucket handle or something you need to do acutely, you can wait and do this later on. You don't have to do it acutely, and the results are similar, even though this study from Canada shows that it's a little bit better in their hands when it comes to the acute surgery within 3 weeks. But I will say that the literature overall says that there's no difference. So I like to operate early, single-stage surgery, and that's probably what the systematic reviews tell us from the literature. Of course, what Rob is saying, start range of motion early, very, very important. That's why you need to reconstruct the torn ligaments so that you have a very stable patient's knee when they get off the table. You know then that you can do early rehab starting the first day after surgery. So I don't think I'll go into this because this is very surgically related, so I'll just skip this. And I'll go a little bit further on. You know, these are full-time knee dislocation surgery, 15 tunnels. 15 tunnels, that's a lot in small bones. So they can collide the tunnels. And, you know, we've done some studies on what to do to prevent the tunnels from hitting each other. Because that's going to happen in the beginning when you are inexperienced in doing this. So we have written a few articles on how to avoid. And you can look at the tunnels here, and there's a recipe for avoiding the conflict between the tunnels when you do your ACLs, your PCLs, your posterolateral, your posteromedial, your meniscus, and so forth. And the tunnels are between 7 and 12 millimeters, so it's a pretty, lots of tunnels, pretty big tunnels actually. Tibia, 5 tunnels there, same thing here. We have a recipe to avoid it, so you should just read our articles. The outcome of knee dislocations are not as good as for PCL, or not as good as for ACL. This is a 13-year follow-up of the 87 first patients we had in Norway. You can see that after 13 years, their mean age was then 49. The Tegner is still very low, so they're not that active, but they can go to work. All those 87 minus 1 did get back to their regular work. No top-level athletes. Lysholm is pretty good, but Lysholm is a very forgiving prom, in my opinion. So it looks very good, it's not that good. And osteoarthritis. They do get osteoarthritis long-term. This is a 10-year follow-up of these patients. So you can expect on X-rays Kellgren-Lawrence, they'll have Kellgren-Lawrence 2 or 3, many of them, when you do follow-up for more than 10 years. So we still haven't solved this problem. This is from Rob's when he was in Vail, and he had 194 patients, and they had very, very good results. So it can be done if you follow the guidelines that this is the guidelines that we have written about over a long period of time. I just want to finish off this because this is a sports conference, and do we ever get any of these back to sport? So let me show you 3 or 4 papers on this, which will tell you that actually, yes, we do get many of them back to sport, depending on the sport, like you see here. So this is a follow-up with 21 studies, and about half of them returned to sport. High-level sports, only about a quarter. But still pretty good, I think, with this kind of problem. And this is elite sports. So 24 out of 26 elite athletes were followed. And here you can see about 1/3 returned to previous level. So between 1/4 and 1/3 will get back to previous level. And the French handball player you saw with the patellar tendon rupture as well, he is actually back to his sport after 1 year. So it is possible to do it. I think the rehab thing is the key here, of course. And also, you have to detect all the injuries that the patient have. Here's another one from NFL in the US, American football. Overall return to sport, 60%. They are very high-level athletes, of course. They have continuous rehab after they have this problem. And some very high-level ones have actually returned to sport, as you can see here. I like this one at the very end here. It takes longer to get back to sport if you have a knee dislocation, meaning ACL and PCL. If they are involved, you can expect 1 to 2 years before they're back to their former sport in some of the athletes. You can read that yourself here. But you can see that the results are not hopeless. And they have improved enormously since I started doing this in the 90s. Much better now. And we can tell the patient that we do have good data if they are compliant in the rehab to recover quite well and reach back to their former sport in many cases. So here's the final one I was going to show you. Very optimistic, 80% back. So you can be hopeful here. The poor prognostic factors are these. Of course, the morbid obesity is not athletes, actually, but their prognosis is not as good as these people. Take-home message here. This is a gymnast from Oslo that also had a knee dislocation. It is heterogeneous. None of these patients are the same. Nobody has very much experience in this. It is very challenging surgery, and you have to sort of be creative and be persistent and be an optimist when you're doing this kind of surgery. So conclusion is this. And she's done very well, obviously, but not every patient does very well. Thank you.
Thanks very much, Lars. So we've got time for a few questions. So I'd like to ask the speakers if they could come from the last session to stand up on the stage. And if you could put your hands up if anyone's got any questions to ask. Got one question at the front here. If we just wait for the microphone to come to you so that the people who are streaming online can also hear the questions.
It's a question for Tim, please. Just with regard to your radial and ramp tears and their repair, what's the initial post-op management that you would recommend in terms of weight bearing or restricting range of movement?
So the root tears, 6 weeks non-weight bearing, stick 0 to 90 degrees. Then again, the radial tears, again, 6 weeks non-weight bearing because they've got to heal end to end. A normal peripheral meniscal tear, you can take full weight, leg in extension. I would use the brace regime, holding a normal peripheral meniscal tear, full weight. But a radial tear, then we need non-weight bearing 6 weeks. A ramp lesion, I don't think alters the rehab for when it's associated with ACL.
This is for Claire. So You put up a couple of studies that have shown that the patients at 2 years are treated non-operatively do as well as ones operatively in an intention to treat. But we know that with some patients, particularly active patients, if they maintain their active lifestyle in the face of an ACL deficient knee, they have an increased chondral risk damage as well as meniscal. And so therefore you'd think that that's going to lead to a more rapid rate of premature arthritis, something that you're not going to see at the 2-year mark. So can you comment on the longer term effects? We certainly know, obviously, ACL reconstruction does not necessarily prevent arthritis, but about the potential for further injury that you might not be picking up at a 2-year follow-up.
Yeah, thanks, Mark. It's a great point, and I think this is the benefit of doing well-designed, long-term randomised controlled trials to compare surgery, ACL reconstruction to non-surgical management. And so I think the challenge is that, as you all know, when an athlete has a meniscus tear or chondral injury, that's the big challenge for osteoarthritis, for post-traumatic osteoarthritis. So my management as a physio doesn't change. My goal is still to protect that meniscus, to protect the chondral surface, and to hopefully try to at least halt the progression of post-traumatic osteoarthritis, if not prevent it entirely. I'm trying to remember off the top of my head the KOOS data at 5 years from the Kanun trial, because those data are published. There's, Lars, you want to add that?
Yeah, I think I have 50 patients, 12 years or younger, when they had their isolated injury. 50. And we have non-operative surgery with active rehab as our thing. And we have followed them from when they were 12 until they are fully grown, more than 18 years old. Within that period of time, 25 out of those 50 have undergone ACL surgery, because they were either very unstable, couldn't function daily life, or they had a meniscal tear that you had to fix. But 25 are doing quite fine. At the time, for the time being, they've only been followed for 10 years. There's no difference. There's no arthritis on the regular X-ray, no Kellgren-Lawrence issues. So short term, meaning 10 years, they do quite well, even without surgery, if you're able to pick out the ones that needs to be stabilized.
And I think maybe the final thing I'll add is that this is highlighting my point about active rehabilitation and this idea of training for the rest of your life, that the whole idea is that we build strength and that continues. So it's not a matter of just, you do a 6-month rehab program and then that's it, done. You need to continue training, and Lars and colleagues and many of the folks who work in injury prevention all around the world will tell you that this is ongoing training and you build it into your normal life. So it's not a matter of I do rehab and then done, I never do those exercises again.
I have a question about the pre-surgical workup for ACL. They obviously have a huge effusion, joint effusion, and the question is it worthwhile aspirating the fluid or leaving the fluid and using a game-ready machine to compress and use the ice to help with that? And if you are aspirating the knee joint, what time, or what's the best time after the injury to do that? And lastly, what the surgeons hate to hear is, do you also put some steroid into that after you've aspirated the knee? And I also wanted to ask about using a hinged brace, because I'm led to believe that you have to avoid flexion over 40 degrees if it's an ACL rupture, so you keep the hinge brace at about 40 degrees. And lastly, about the talks with the bony anatomy, because that wasn't mentioned, we all have leg length shortenings, but how relevant in the preparation, the bony imaging preparation, is it relevant if someone has a significant leg length difference for the success of an ACL repair?
How about I start as the physio and then I'll pass the mic along to my surgical colleagues here. As a physio, my goal is very much quiet knee, and you'll hear a little bit more about that in the OptiKnee session or when I speak about the OptiKnee consensus after the coffee break. But it's really about settling that knee down, reducing effusion, getting rid of pain, getting strength back, and doing some quite high-level training before getting into ACL reconstruction from a physio's perspective.
Andy, you want to say something about the blood thing?
Thanks, Laura. So the blood in a joint is not great. We've done a study of injured knees, mainly professional footballers and rugby players, and studied the inflammatory mediators. And the one thing that correlates with bad outcome in terms of chondral damage is the presence of a hemarthrosis. So there is a case for washing it out. The problem with me is athletes, professional athletes, won't wait. And on occasion, I have decompressed the knee by aspirating it. You have to be very careful in terms of sterility, etc. But as soon as the effusion's gone, they can get their quads going and they can prepare themselves for surgery. So if we've got a really tense knee, there is a place for it. In practice, it was frowned upon to aspirate joints because of the risk of infection, and it's completely dropped out of practice. But because of my rather bizarre life with athletes, I do have to do it sometimes. I would never put steroid in. The association with infection is significant if you're going to operate. If for some reason you weren't going to operate, there would be a case for it, I suspect. Hinge braces, I don't think you necessarily need to brace. If you've got good neuromuscular control, there's something magical about letting people weight bear and move naturally. And the leg length discrepancy, we don't really understand the impact of that, I think, at the moment. Is that all your points? I'm showing off. I got them all right.
Rob, do you want to say something about tapping the knee? Go ahead, Martros.
I agree exactly what Andy said. I rarely aspirate unless they're in so much pain because of the effusion is just so tense that you'll take it out, and that's trying to be treating them as a human more than anything else. But I don't really like to stick a needle in if I don't have to.
I think generally I'd say I brace less and less for all across the board. I think there are certain indications, the PCL type brace that Rob is the most common reason I brace the knee, but it's interesting, if I do operate on a collateral ligament, it should be fixed well enough that you don't need to brace often. I tend to put them in just for a short period, but less and less.
Say something about him.
I probably use braces more in the early situation just to enable people to be functional. Not so high-level sportsmen that I'm seeing, but for a person who wants to get back to activity or back to school, college, university, then to put a brace on, a sleeve support enables them to be functionally more active. I'm not using them post-op. The PCL brace very different. That's made a big game changer.
Just a follow-up question here for Rob. There's historically some data, some guidelines that suggest acute position of bracing. So if our sports medicine or physiotherapy colleagues see patients in the acute setting, do you have views on the safe position of bracing if we're just suspecting an ACL injury acutely or ACL plus MCL?
I don't think you have to limit motion for that, but you have to worry about looking at your tibial-femoral position. So if there's a risk they're going to slip posterior, then you want to push them anterior. So the PCL braces have been validated with clinical studies to show that it holds the tibia in a better position. Most PCLs heal. You don't want them to heal in a loose position. You want them to heal in a tight position. So acutely using a PCL dynamic brace works very well. There's new braces now for ACL dynamic braces. We don't have enough data to show whether that makes a difference on healing. It does make a difference in protecting the meniscus. Those studies have been published. We don't have the data yet to show if it helps on healing. But I don't think limiting range of motion for any of the ligaments that we treat necessarily needs to be done.
So when it comes to knee dislocations, they may be very, very loose. So if you have a knee dislocation with a vascular injury, you fix the artery, you put an external fixator on for about 6 weeks. Then you take it off, then you rehab the patient, and then you do the surgery about 3 months later. But we don't really use a brace for that. But if you have no vascular injury and knee is very, very, very loose the first day, to be able to get it to quiet down, get the swelling down, things like that, then we use a brace, just like you guys use a post-operative brace for those patients.
Okay, I think.
Can I ask Claire a question? The ACL SNAP study that you're talking brilliant all about early management of ACL. When you're not doing well and it's more of a chronic situation, the UK ACL SNAP study published in the Lancet then for the chronic ACL showing that surgery better functional outcome than conservative treatment. Your view on that?
Thanks, Tim. I think the SNAP trial, congratulations to our colleagues in the UK for the SNAP trial. The challenge, I think, one of the issues, or not issues, but one of the challenges I think with the SNAP trial is I have concerns about the rehabilitation that athletes or patients in the SNAP trial have had. I think they had all come from the NHS and it's hard to know exactly what type of rehabilitation people have had. We saw from the Australian data that usual care and even the Norwegian data, usual care is not good enough. So I agree that there's a whole lot more that we need to understand about how patients are doing in the long term, and that's something that we need, as I said, those really well-designed randomised controlled trials to help us figure out.
Okay, one final question from the front.
Thank you much for these fantastic talks. I have a question to Dr. Loprade, if I may. Pediatric patients, skeletally mature with PCL injury, not responding to dynamic PCL, significant SAG. Any consideration for these? That's number one. Number two, to the panel, really question, any technical consideration for meniscal root injuries in pediatric age group, again, for our sports persons?
Skeletally immature PCL. So the question is on skeletally immature PCLs. That's a tough question. So I see 9 and 10-year-olds now that are having PCL tears, that their stress x-rays are 14, 15 millimeters, which is significant in an adult. And it's very difficult to reconstruct them because you're going through the physis and you can't really avoid the physis because of the attachment site. So what we've been doing is placing them into the PCL rebound brace and getting them custom fit and waiting until they're skeletally mature. We've got like 4 or 5 patients, so it's not huge numbers, but it seems to work. They're able to play some sports. They don't have effusions. The serial MRIs don't show that they're developing arthritis. So conservative treatment, making sure they're doing the rehabilitation as they go along and wearing the brace to hold them in better position seems to work. You can probably operate on the physis that is open a little earlier than you could with an ACL, because when you get your x-rays, most of the time they're going to have a flat slope. And if you operate on the physis and stop it from growing, it's probably going to increase, but you have to make sure that they're getting close to skeletal maturity because you don't want to over-treat them and have a big increase in slope. So we do have a patient that was treated in California that had, Marcus helped me on this case, that had a avulsion fracture with a fixation that actually stopped her growth in the back when she was 10, and at 13 I did her double bundle PCL reconstruction. Her slope went from 4 to 12, so that was protective, but her PCL stress x-rays also went from like 15 to 7 during that time frame, but she was still symptomatic. So the skeletally immature are tough. Luckily, they're not too common, but using a PCL brace to hold them in better position seems to help protect the articular cartilage.
Tim, do you want to have the last word before coffee?
So I just wanted to add to Carrie's talk on the assessment of the knee. Another frustration is the delay to diagnosis of ACL. We see how long, and patients going back to sport having not picked up a diagnosis of ACL. So I would really urge, all we have to do is to pick up Lachman's test, increase movement compared to the other side, equals an ACL, refer on to make that decision, not going back to sport. It's a frustrating length of time in England for that delay and not picking up ACL from going to A&E or in the primary care setting. You agree, Andy? Yeah.
No, I definitely agree. Because of the number of women, high-profile women's ACLs in football at the moment, I've been interviewed 3 times. I was on Radio London, and one of the professional female players didn't have a diagnosis for 8 months, and she's dropped 2 leagues. It's shocking. And because the first team men's, all the investment, they get the best of everything. They'll have 2 scans in a week. The women get bugger all. It's disgraceful.
Okay. Yep. Thanks, everyone. Welcome back, Enda King, who is Head of Elite Performance and Development at Aspetar, and he's going to tell us about rehab and return to play criteria following ACL injuries.
Thank you very much, Ian, and fantastic presentation as always, Claire. Teed things up very nicely, hopefully, for what's going on and following on from this morning's session. I love ACL rehabilitation. As a clinician, there's very few injuries that really challenge you in terms of your ability to restore homeostasis to the knee, to work on developing exercise programs to develop muscle mass, to influence the nervous system, how you redevelop human movement and then try and express that on the field of play. It's a fantastic challenge, but also can be sometimes quite a frustrating one. And the other enjoyable thing about it is that there's more than one way to do it. There's no one way of rehabilitating an ACL. Certainly in Aspetar, our process is trying to work out what's best practice and ensure that continuity and consistency between us. And my colleague Rula Kotsafaki has done a huge amount of the heavy lifting in this and trying to review the research to find out what is best practice currently. And I say currently because it's a constant evolution and development. But what are we trying to achieve? You can rehab away, you can do a lot of work, but what is the ultimate outcome we're looking for? And for the most part, athletes will tell you the reason I'm having my reconstruction is to get back to play or get back to my previous level of activity. But as Claire has shown both in her presentation and previous work, we're not always necessarily successful in returning to play, and when we do, we don't always necessarily play our best or avoid second injury. So return to play is very often only a stepping stone on the journey. And perhaps from a rehabilitation point of view, return to play is not what I should be aiming for, but have I fully rehabilitated my athlete? Now, the question is, what is a fully rehabilitated athlete, and what does the end look like? Our surgical colleagues go to great efforts to try and restore normal stability in the knee, restore normal anatomy where possible, but certainly from a rehabilitation point of view, we're not always very good at restoring normal function, or at least back to what they were baseline before that. And so very often we return to play in spite of ongoing and persistent deficits, and that influences the ability to get back to the highest level of play. For our American colleagues, just to point out that that's the Irish rugby team, who are the #1 team in the world, in case our English colleagues forgot to mention that to you on your travels. So from a rehabilitation point of view, what are we ultimately aiming for? There's a number of outcomes. Of course, we want to return to play, but we want to do it without any knee symptoms, both in the short term and the long term. We want to minimise the risk of second injury, not just to the operated side, but you're probably twice as likely to rupture the contralateral knee on return, and ideally to return to performance. And there's a whole host of factors outside of the rehabilitation domain that influence that: graft selection, remodelling, and obviously surgical technique. If you're going back to cycling, it's very different than going back to change direction sports in terms of the demands on the knee. There's a huge amount of psychosocial factors that we could spend a day talking on its own. But from my point of view, what am I judging the work that we're doing on from a rehabilitation point of view? Obviously, there's a sport-specific skill and conditioning element to it, but in specific in relation to our physical tests. And so whether you are a physiotherapist looking after an ACL, or you're a club doctor involved in decision-making around return to play, or you're an orthopaedic surgeon, what standards are you setting for your athletes? Before they have their surgery, are you able to highlight what levels of strength you expect them to achieve in what tests? What levels of explosiveness and plyometric or reactive strength? What movement quality you expect them to achieve when jumping and landing and running and change direction? If I can't outline this before I start the process, how am I going to check that from a rehabilitation point of view I'm heading in the right direction and consistently meeting my goals? So I've been very fortunate to have done my PhD on the role of biomechanics after ACL reconstruction. I've also been very fortunate where I work currently in Aspetar and where I worked previously in a sports surgery clinic to have a biomechanics lab. There's nothing more humbling to have your rehabilitation work reviewed every 6 to 8 weeks. You find out very, very quickly where there's inadequacies in your programming and where you're inconsistent in your approach towards that. One of my first PhD studies looked at biomechanical deficits in male athletes at 9 months post-ACL reconstruction across a range of tests: double and single leg drop jump, single leg hop for distance, and a lateral hurdle hop. And there's a couple of very interesting parts that, regardless of which test you use, there was very, very consistent biomechanical deficits in these athletes, despite the fact that they were returning to play. There was ongoing deficits in the frontal plane of the knee, whether that was valgus moment or rotation angle, and ankle rotation moment, despite having undergone a complete rehabilitation program. Not only was there deficits in the frontal plane, but there was also deficits in the sagittal plane, where in this cohort, where the majority were patellar tendon grafts, there was ongoing knee extension moment deficits. And those knee extension moment deficits represented themselves differently in double and single leg tasks. In double leg tasks, they tended to put more weight and shift across to the contralateral side. In single leg tasks, you can't do that, so they ended up bringing their centre of mass forward to try and manipulate and compromise the knee extension moment on that side. It's often easier to look at videos than look at graphs. So this is an athlete 9 months post ACL reconstruction. The green knee is the operated side. The red knee is the non-operated side. You'll see a couple of key factors when he lands initially. If you look at the red arrow is the ground reaction force. You can see how much force he's putting through his healthy knee compared to the contralateral side at 9 months. You can see how the red arrow is sitting outside, driving the knee inwards, causing a valgus moment on his operated side, where it's sitting very comfortably inside the non-operated side. So again, they're passing their isokinetic test, they're passing their jump height test with persistent biomechanical asymmetries and deficits. And it was very reassuring when I moved to Aspetar. Rula Katsufaki was doing very similar work at the same time and found that regardless of where you are in the world, everyone's having the same challenges. That despite our athletes passing the commonly used HOP tests and strength tests, they were having ongoing and persistent biomechanical deficits that were influencing not only their performance, but how that knee joint was loaded and the short-term and therefore potentially long-term consequences that can have. So again, using a HOP for distance, very commonly used metric, having achieved symmetry of HOP distance, having persistent offloading and reduced knee extension moment on the operated side. So that's all well and good. The question is, what are we going to do about it? I firmly believe there are no good or bad exercises. There's no one way to rehabilitate an ACL, but we have to appreciate that there's these common deficits that my programming or the way I'm coaching those exercises is not achieving change. We focus a lot on the ability to jump, but actually the main deficits are in the ability to decelerate, trying to coach them to adopt and absorb in deeper knee flexion angles and doing it under load. We jump with weight, why don't we land with weight, especially under high intensity? Similarly, everyone gets glute exercises. You've shoulder pain, you get glute exercises. You've concussion, you get glute exercises. But how often are we expressing that hip strength and especially the motor control around the foot? And we talked about this with hamstring yesterday. How often are we manipulating those exercises dynamically to ensure that we're building these fundamental patterns that we're going to use when we go back to running and change direction? It's not enough to say, keep your knee out or squeeze your backside when you're doing that exercise. Lunging, running, change direction are motor skills, and therefore you want to provide perturbation, you want to provide distraction that's going to allow them to develop those motor patterns robustly, especially when they move on to higher levels of activity. While we're all keen to get back to play, one of the things we're most focusing on is avoiding second injury, and most testing batteries are unable to predict second injury to the operated side, but you're actually twice as likely to injure your contralateral side as you are your operated side. And so we prospectively followed a large cohort of male athletes over a 2-year period, and 55 of them went on to rupture the contralateral or previously healthy knee. And when we looked at their testing at discharge at 9 months, we found that when we looked at the healthy knee that went on to rupture compared to the healthy knee that didn't go on to rupture, there was no difference in strength, jump, or change direction performance on that side. There was slightly lower quadriceps strength on that healthy side that went on to rupture than those that didn't, but it was not predictive of future injury. And despite my hypothesis that I don't do a good job of rehabilitation, I have persistent asymmetries, and those asymmetries leave me susceptible to injuring the healthy leg. At 9 months, asymmetry measures made no difference in those that went on to rupture their healthy knee and those that didn't. There were, however, a number of biomechanical deficits in those that went on to rupture their healthy knee. And we can focus more on these because it doesn't take in graft selection, graft healing, surgical technique, etc. Those that went on to rupture their healthy knee were less springy on that side. During double and single leg drop jumps, they had longer ground contact times, they had lower reactive strength index, they flexed more at the hip, knee and ankle, and had changes in centre of mass stiffness and moments accordingly. So why might this be important in relation to ACL injury? When you rupture your ACL, or when someone ruptures their ACL, they do it in the first 40 milliseconds after ground contact. That's not enough time to send a message saying, shit, I'm in the wrong position, I need to correct myself. It's not enough time even for a spinal reflex. So the amount of activity, the co-contraction you have in your neuromuscular system prior to ground contact is going to greatly influence the load on the knee when you do strike that. The springier you are, the better your level of plyometric ability, the more activity you have in your nervous system, your neuromuscular system prior to ground contact, and it may be an influencing factor. And you look at, there'll be talks later on injury prevention. Most of the most effective injury prevention programs have some form of jump landing and especially plyometric exercises included in them. So how can we identify during the rehabilitation process who's going to go on to second injury? Our Norwegian colleagues asked a large cohort of professionals to examine athletes, female athletes, doing drop jumps, and could they pick out who was going to go on to second injury? And the answer was no, they couldn't. But like all things, it kind of depends on what way you look at it. So this is one of my former colleagues in Dublin. No physios were hurt in the making of any of these videos, I just want to point out. So we'll have a vote among the group. Which side do you think he is more susceptible to ACL injury on? And for the record, you don't get lunch if you don't vote, okay? So we'll play it for a minute. Do you think it's his right side or his left side? Excellent. So I'll super slow-mo for those of you that the coffee's wearing off. Hands up if you think his right side is the side he's more susceptible to ACL injury on. Good, and hands up if you think it's the left side. Good, I like when there's a bit of controversy and argument in the group, okay? For the record, and to my knowledge, he is not, that video was maybe 6 years ago, he has still not undergone any ACL or knee injury. What you often see is people will say it's his right side, because you'll see the foot externally rotated. You often see a valgus motion on the right side compared to the left side. We know that female athletes tend to rupture their ACL in more knee flexion, more hip flexion and more knee valgus than male athletes. The question then is how much valgus is too much valgus. But what if we look at him in a different plane of motion? So if we look at him in the sagittal plane and ask him to do cone hopping instead. So that's his left side. So I think we can agree he's definitely more springy on his right-hand side than he is on his left-hand side. And how might that influence our interpretation of his ACL injury risk? Well, what you can see is on the left-hand side, his heel hits the ground every time. He's poor ankle stiffness. That really means when he's hopping forward, he struggles to control that anterior translation. That anterior translation is one of the primary ways we're going to influence ACL loading. And while co-contraction of the quadriceps and the hamstrings are very important, ultimately that ankle dorsiflexion is going to play a big role in tibial translation. When we compare that to so heel hits the ground, struggling for ankle stiffness, so tibia shoots forward, and obviously he's not very springy. Heel never touches the ground. Very, very good tibial control throughout all the hops, and he could bounce all day in comparison. So again, depending on which view, you might say his right leg or his left leg is the most susceptible. But about 50% of ACL injuries are during change direction. So again, the vast majority of our tests are hop tests and strength tests, but 50% of mechanism and field sport is during change direction. So we looked at the same athletes during the jump paper, during 90 degrees planned and unplanned change of direction. And we found that there was the same asymmetries between limbs at 9 months, whether it was planned or unplanned change direction. And despite the fact that the time it took them to change direction left and right was no different, there was marked biomechanical asymmetries throughout the cohort. So again, if you're doing a T-test or an Illinois test, obviously there's a performance element to it, but it's often hiding numerous biomechanical asymmetries that were evident in what we saw in the jump test. So again, ongoing deficits in the frontal plane around valgus moment, rotation moment at the knee, but especially reduced knee flexion angle and reduced knee extension moment. So they go into those change of direction maneuvers, offloading that knee by keeping it more extended, and the inability to absorb force, which will have performance and knee loading influences. So as I said, change of direction is a motor skill. So the idea is not to tell them bend your knee or don't let your knee collapse into valgus. The goal is to give them drills where those patterns will emerge over time. And this is one of my favourite drills. It will be if I can play it properly. The lateral shuffle. The stick is a phenomenally useful tool in rehabilitation. When you hold something with locked arms, you can no longer trunk side flex, therefore your lower limb needs to work out how to best problem solve and work that out. As long as you're coaching short ground contact times, the band will not allow him to spend too long on the ground. It'll encourage that higher ground reaction force, and he'll have to flex his knee in order to be able to absorb to push off. You can progress on to higher intensity singular efforts. If you watch his left side compared to the right side, you'll see the left elbow bending. And to be fair to Yusenko, he's a marathon runner, not a change direction expert, so you have to pick out your best one there. But again, coaching short ground contact times, being explosive in the push-off, and not telling him what to do. Give him a problem to solve and let the patterns emerge as we go along. Just to finish up then in terms of running mechanics often doesn't get the same attention that jumping and landing and change direction does, because it's very rare to rupture your ACL running in a straight line. However, from a rehabilitation point of view, return to running is a big landmark for the athlete. The first question is, when can I return to play? The second question is, when can I start running? And it's often one of the things that gives us the greatest challenge in terms of knee fusion and anterior knee pain, is that transition back to running. Part of that is because most people judge the success of running on how much running you're doing, not the mechanics with which you're running with, and how that influences not just overuse of the knee, but performance as well. My colleagues in Aspetar have looked at the influence of isokinetic symmetry on ground reaction force symmetry in time post-surgery, and what they found was that there was no difference in ground reaction force symmetry when running at 10k an hour, whether you were greater or lesser than 90%. So whether your quads and hamstring strength was greater or less than 90% had no relationship to your ground reaction force asymmetry. So they're very separate qualities. And the other thing that had no influence on it was time from surgery. So whether you are 12 weeks or 20 weeks or 35 weeks, that doesn't necessarily mean I have any idea of what your ground reaction force asymmetry is. So again, you need to assess and intervene accordingly. And it's not only, again, looking at around the knee and looking at those ground reaction force asymmetries. It's important that you're constantly identifying the frontal plane deficits that we're seeing in the jumping and landing. So on his left-hand side, relatively neutral pelvis, relatively neutral trunk, relatively neutral foot. Black on black is difficult to see. On the contralateral side, you can see the trunk side flexion, you can see the pelvic drop, and you can see 3 or 4 toes on the right-hand side compared to the left-hand side. So he's back to play, he's back running and sprinting, but there's a legacy from his previous knee injury history on that side. So just to summarise, I think we can talk about, our favourite exercises. You can go on Instagram and find 100 different things to do. The question is, what am I trying to achieve? And have I communicated that effectively to all the stakeholders involved, but especially the athlete? Can I tell them how much strength is enough strength before I start? How much explosiveness and reactive strength? And not only the ability to leave the ground, but the ability to come back down as well. My jumping and landing mechanics are only a piece of the jigsaw before I go on and express that during running and change direction. And then ultimately how you piece all that together. We know that the physical component is only one piece of a successful outcome afterwards. But given the fact that the role of rehabilitation is to restore normal function, if we don't identify what normal function is at the beginning and continually reflect back on our practice, how do we know if we're achieving the outcomes that we're looking for? While the weather in Edinburgh is exceptional in June, the weather in Qatar in November is also very pleasant. We're having a conference focusing entirely on the rehabilitation of ACLs. We're very lucky to have an international faculty coming. So on the off chance you're looking for some winter sunshine, I hope you'll be able to join us in November. Thank you very much.
Thank you so much, Eda. So it's my pleasure next to introduce Dr. Cherie Becker. She is a sport injury researcher and a senior lecturer in the Department of Health at the University of Bath and part of the UK Collaborating Centre on Injury and Illness Prevention, and always brings an incredibly unique and important perspective to sport injury. So thanks, Cherie.
Thank you so much, Carolyn. Good morning, everybody. So I am a sports scientist. However, I have always done all of my training and my work within sports science in faculties of humanities and social sciences. So I really bring a social science perspective to a lot of the questions that we ask within the area of sports injury prevention. And my talk today and my research really looks at a comment that somebody made earlier at the end of the last session around, they said that a woman athlete had had to wait for her ACL diagnosis for 8 months. And so my research really looks at that. And this talk is called Flipping the Script, so looking at a gendered environmental approach to sports injury prevention. So, because I am a social scientist and also a qualitative researcher, my research brings, as Carolyn said, some new and different considerations and ways to look at old problems in new ways. So my research doesn't provide any hard and fast answers, but really opens up new considerations and questions, as I said, for looking at old problems in new ways. And one really good example of that is this dress. I'm sure many of you remember this from quite a few years ago now, which is the kind of image that all of us look at and we see the same image, we see the same data here, but we have different interpretations of this image. So very clearly to me, when I look at this dress and I ask what color or what colors is this dress, the right answer to me is that it is white and gold. So how many people see white and gold? And we're always in the minority for some reason. Everybody else will see, this is not the best quality image, but I think everybody else sees blue and black, which is absolutely bizarre to me because I cannot see blue and black here. And really the point that I'm making here is that we look at the same data, but we have different interpretations, and these interpretations are subjective. And if we don't ask and speak to people, we will never know that we actually are seeing different things even though we're looking at the exact same image. And so this is what qualitative research and social science approaches brings to sports injury prevention. Now, the work that I'm going to share today is some transdisciplinary work that I've done with my colleagues, Dr. Joanne Parsons from Canada, who's a physical therapist, and Dr. Stephanie Cohen, who is a health geographer now based at Nottingham. And so we bring these transdisciplinary approaches to looking at girls' and women's sports injury, and our work is very much inclusive of gender-expansive people, so we are interested in trans people and non-binary people as well within our work, increasingly important within the context of sport. And this presentation today focuses, or the work that we published on this focuses on ACL injuries. However, this is really relevant to any injury, including concussion. This work was editor's choice in the British Journal of Sports Medicine, and you can go and read it. It's open access there. I will also mention at this point that this is the only piece of research that I've done where I've had more athletes reach out to me than any other group of people. Athletes, women athletes in particular, have read this whole piece of research and often reach out to say, this really resonates with my experiences and we wish we could talk more about the things that we're saying in this study. So, what do we say in this study? First of all, we talk about sex and gender, which I'm sure you're all very familiar with. Currently, in sport and exercise medicine and in biomedical practice more recently, we think of sex and gender as two very different things, right? We think of sex as the physiological characteristics, and we think of gender as the sociocultural characteristics of a person. Now, that's been a really useful way of looking at sex and gender, and I think it's helped us to answer some really important questions within our area of practice. However, what I think we need to be looking at is this compound notion of sex-gender. And sex-gender is something that we're seeing more and more in anthropology and in the social sciences, a compound term being used to recognize both the empirical and conceptual entanglement of both the social and biological factors in our expressions of who we are. So this acknowledges dynamic processes and interactions through which our body-based characteristics are shaped by gendered social interactions. And what I mean by that is there is increasing evidence to show that our physiology, sex, is actually influenced by gender, by the social characteristics. And our physiology actually changes through our lived experience of gender. And I'll talk a bit more about that today. So in my research, we're trying to move away from this idea of sex binarism, thinking about only male and female athletes and only thinking about physiology, biomechanics, and so on, and towards a compound idea of sex-gender contextualism, so looking at athletes within their context. So we know, and I think we've heard quite a few times at this conference, that girls and women are 3 to 6 times more likely to experience ACL injury than boys and men. I think some of the latest data is showing 3 to 9 times more likely. And we also know that over 30 years of research and more than 32,000 research studies have failed to decrease the ACL injury rate in girls and women. So clearly, we need to look at this old problem in new ways. And so we say that it's time to flip the script. Now, when we flip the script, there are some common taken for granted assumptions that we have about girls' and women's bodies, right? So when we flip the script on this, we need to flip the script on this idea that girls and women are inherently injury prone, and that girls and women are inherently weaker and just inferior to men and boys. And so we need to look at how girls and women are actually made injury prone, and I'll tell you a bit about that today. We want to move the focus away from being solely on women's bodies, so women as Q angles or as menstrual cycles. I think Kate Crosley says women as hips and hormones, which is what we hear all of the time, and to consider social and environmental factors, and to move away from marginal gains such as menstrual cycle monitoring and towards meaningful gains, so gender equitable environments. And flipping the script, I think, can have a really powerful influence on how we ask questions and how we approach injury for girls and women. So the overarching purpose of our work is to identify how gendered environments operate in sporting contexts, what the impact and implications are for athlete health and performance, and to develop practice recommendations for application. So I promised that I'd explain to you how gendered environments show up in sports. So how we make girls and women prone to injury. Now, this is a TikTok video from Sedona Prince at the NCAA Women's Basketball Championships from a few years ago. So I'm just going to play this for you to show you how these gendered environments show up.
I got something to show y'all. So for the NCAA March Madness, the biggest tournament in college basketball for women, this is our weight room. Let me show y'all the men's weight room. Now, when pictures of our weight room got released versus the men's, the NCAA came out with a statement saying that it wasn't money, it was space that was a problem. Let me show y'all something else. Here's our practice court, right? And then here's that weight room. And then here's all this extra space. If you aren't upset about this problem, then you're a part of it.
Right. So I think that is an excellent example of what we expect of girls and women, right? And it's even girls and women at the elite level of sport, that of course they won't want to be doing weight training because they don't want to bulk up and look manly in any way. We want to keep them just doing cardio and just doing like the small weights. And my favorite part of that video is when she goes, and here's our weight room. The other things that we saw at the same championships were that men were given 500-piece puzzles within their swag bags and women were given 150-piece puzzles because clearly women have smaller brains than men as well. So we think feminism has solved these things, and we think that, we are now at a point of women's equality, but clearly this shows up all the time, even within elite sport. And so this makes me think what happens at other levels of sport as well. So for us, a gendered environmental approach shifts the paradigm from a sole focus on women's biology to consider how gendered exposures, so for example, how these gendered weight rooms may place women's bodies at risk. Because if women are not being encouraged to do the kind of basic weight training and strength and conditioning that they need to be doing to prevent injury, then, obviously, I think women are being made injury prone. They're deliberately being kept small through our societal factors. So this moves us beyond biology and individual level interventions to consider how we can modify those kinds of environments to reduce injury risk. Now, I just want to talk briefly about risk factors, and I think an important point that we're moving towards. So I'm sure I don't need to tell this room that we used to think about risk factors as intrinsic and extrinsic risk factors, and that's depicted here by those things outlined in red. And then we moved forward into a, I think, more useful idea of modifiable and non-modifiable risk factors. What I find really interesting is that we still think about sex and race as non-modifiable risk factors. And if I want to leave you just with something today that I'm happy to talk to people more about, is I think we need to move away from thinking about sex and race as non-modifiable risk factors and think about them as modifiable. Now, how can sex and race be modifiable risk factors? Well, if we flip the script to thinking about sexism and not sex as the risk factor, then our interventions can become much more useful because we can change things like people's perceptions about women's weight rooms and the need for strength and conditioning training. There's also new research to show, and we've seen this in other areas of medicine, that we need to recognize racism and not race as the risk factor for injury and illness prevention. And I'm currently doing some work with John Dresner and colleagues around sudden cardiac arrest and racism, and we hope that that work will be published later this year. So anyone who is interested in that, please do look out for that work. So we need to recognize that ACL injury can be conceived, at least in part, as a biological manifestation of cumulative exposure to exogenous social loads. So that social load of sexism or racism that renders the body susceptible to injury through our lifetimes. And so this comes from that BJSM paper that I mentioned right at the beginning. So what we did in our paper was to overlay a traditionally well-known injury cycle with a gendered environmental approach. And we looked at the pre-sport environment, the training environment, the competition environment, and the treatment environment to see how those gendered exposures play out in those contexts. So just very briefly, the pre-sport environment, we looked at how young girls are treated from the time that they're babies, very different from young boys. Young boys are encouraged to be more physically active, rough and tumble play, where young girls are encouraged to be more passive, right? And how that plays out into ACL injury over the course of a lifetime. Training environment, for example, we looked at gendered socialization in strength and conditioning training, how weight rooms are highly gendered spaces, and so on. And in the treatment environment, we looked at gender differences in return to play timelines and rates after ACL injury, and relevant to this room, gendered biases in recommending reconstructive surgery where that is indicated. Again, that comes back to that example earlier about the 8-month wait. So the outcome for our work is to create more gender equitable and supportive environments that promote athlete health and performance. So going forward, applying a gendered environmental lens, we think that we need to move beyond a biological starting point, which, to be fair, has been really helpful up until this point, but I think we need to go further now to look at those sociocultural influences. And by overlaying gender or racism as a pervasive developmental environment onto existing approaches, we can ask new questions. And so, for example, we can't just simply tell girls and women to get stronger to reduce injury risk if society and the environments are not supportive of that kind of injury prevention. And we need to look at things like focusing on goals and performance gains rather than appearance, for example. And finally, determining if gendered roles and responsibilities may interfere with an athlete's progress in sport and rehabilitation. So we know that many women athletes are not on full-time professional contracts that allow for them to undertake the rehabilitation that they need to, for example, or even the training in the first place. So final example from me. So this is an artist's rendering of the new home of the Matildas, the Australian national women's football team, at La Trobe University in Melbourne. And I was really curious to see that this was a centre that has been billed as a centre designed by women and for women. And I should mention at this point that this anecdote here is despite our amazing colleagues who work at La Trobe and who are world leaders in women and girls in sport. This has nothing to do with them. So this is a centre builders designed by women and for women. That sounds amazing, right? That sounds like something that we need to be doing. And yet, we need to recognize that even when women are doing this work, or when we're doing work with women and girls, it doesn't mean that gendered biases don't bleed through. So I'll give you this. They said that in this new centre, there's less of a focus on power racks and heavy machines, and more on cardio and equipment designed specifically for women. So I hope you get my point now. Yes, that, at first glance sounds great. We need, equipment designed for women. But when we really look at injury prevention training, that is not helpful to girls and women, and it is designed in a sociocultural way to keep women small and makes women more injury prone. So looking for where these biases bleed through in our research and in our practice is really important. Now, please don't share this publicly, but this is a new piece of research that we're undertaking with the UK Sports Institute, the SheFast collaboration, looking at some of these gendered environments. And so we've done the theoretical work, and we're now moving that into empirical work, and I hope to share some of this work with you very soon. So I think that we need to be transformative, and we need to transform the ways that we think and research women's sport, women's sports injury prevention, and we need to look at the untapped gains of taking a gendered environmental approach, because I think that this outweighs marginal gains that we might have been making before. Final point, just a little pitch. I am also one of the co-editors of a special journal issue of the Sociology of Sport journal called Sport and the Limits of the Binary, and we're looking at trans and non-binary athletes and equity in sport. So if you are aware of anybody who is working on that space, we'd really welcome their work submitted to that special issue of the journal, and I have a QR code there for you. Great. Thank you very much, everybody.
Thanks so much, Cherie. We hope that that wasn't just a talk that captivates everyone in the hall, but also leads to some real action. So, final talk of this session. Lars, welcome back. You're one of the leaders of ACL injury prevention, and we're all really excited to hear about your work.
Thank you. It's very difficult to come behind a talk like that, which was very thought-provoking. And maybe I'll add some practical things to this. Because I'm going to talk about current prevention strategies in ACL prevention, in handball and soccer, primarily in females, actually. So maybe I'll give you some data. What do we know? What do we do? What kind of implementation issues do we have, practically speaking? And what's the next step? How can we improve this? Well, just some facts. Soccer, team handball, lots of knee injuries. You know all about that. Those are stats from Norway, actually. And some papers telling you what we know. Soccer, handball, and soccer. We know that prevention helps in those sports. And again, here, soccer, handball overuse, shoulder injuries, they all show about 30 to 50% reduction of injuries in these sports, in these papers. Acute injuries and chronic injuries. And the FIFA 11 Plus warm-up program, basically in soccer for youngsters, does really work quite well. You can see here. I think you can click on this if they will, the videos will work. Maybe I can do it. No? There's supposed to be some videos there, but you can see that. You can imagine. Here they come. Yep. Then there's one. No, there's just one. Anyway, very easy program. It reduces the injuries in these kind of sports by about 50% in soccer, in youngsters and in females and men. So it does work. All injuries in these women and men, youngsters, reduce 30%. Severe injuries, meaning ACLs, 45% reduction. And overuse injuries, 50% reduction. So there is no doubt that these programs work on the research basis. So in handball, team handball is a ACL-prone type of sport, just like your netball and things like that, basketball. Reduction when you do training like this is about 35%. ACL prevention in soccer, this is a study from Sweden. Very simple. These are young junior players. And again, the knee control is what they are especially training on. And here, 60% reduction on this research study from Sweden. Very, very good results. If you look at hamstring injury prevention, hamstring is obviously very important for ACLs, for example. And this is the program that you will see. And this is how you do it. You should not try that now, because it's a little bit dangerous if you haven't done it before. But the thing is that it really, really helps when it comes to prevention of hamstring injuries. So, you know, this should be done also by English Premier League players, because this is something that's so obvious. It really works, and it's free. You don't use any extra equipment. You need to have an assistant to help you with it. So very much reduction, 81%, you see that? Really, really good. Groin, same thing. Studies show that groin injuries are very big in football, men and women, and the prevention shows that these are reduced by 40% if you work on this for about 6 months. So there's no doubt that injury prevention is doing quite well. I just want to show you this to make sure that you all know that there are good research for these types of prevention programs. Again, this is one for team handball. Lower risk of shoulder problems in general. And no doubt that this works. Strength, coordination, biometrics, technique, running exercises, and there is no difference between men and women here. It works for both of them. No difference between men and women on this one. So my point, this is my point. That's where I'm coming to now. Because the issue about these programs, which work remarkably well, is that the implementation of them is very difficult. And why is that? I can show you a few things that you could probably work on to make them better. One is that the coach always asks us, what's in it for me if I change the session to incorporate this type of, I don't have the time to do that, it takes too long. I don't think we should do it more than once a week or something like that, when you should do it every day. So you need to, I will tell the coach then, well, you probably have many more available players. They will be 100% ready for training. They will probably altogether improve the team performance. So that's something you can discuss with the coach. You have to identify in your team barriers, misbeliefs, resistance to change, because that's happening in all the teams. That's a practical experience I have, because I've been doing this now for 22 years, something like that. And you have to understand that the coaches have lots of knowledge that you probably don't have. And you have to acknowledge that they have their expertise, and it can be helpful to get better compliance in this area. Then the player, she will say, why do I have to do this? What's in it for me? And then the point is that, well, I can tell you, you can train and play every day. You can probably not miss any matches. You're 100% ready to perform. And you will actually develop as a player. And not the least, you'll have a much longer and better career in your sport. So those are variables you should discuss with your player. Because to identify barriers with the players is as important as doing it with the coaches. Facilitate discussions, provide facts about best practice. That's your role in this case. Next step, finding and minding the gap, because it is still not working that well. And I'll show you a little bit of that. We made 2 apps. I will show those to you. They are financed by the IOC and mostly by the Oslo Sports Trauma Research Center in Oslo. So I'll show you how we use them. This is the Norwegian one. And here you can see this is the group who is working with the schools and with the teams. There are 5 full-time researchers doing that at the moment. And this is what they're doing. I will show you a little bit of that. This is the app called, and you can download it for free. It's called Fit to Play. And it shows you different sports, different problems. I'll just show you a couple of examples. There's an injury prevention program for that area, but there's also a direct treatment program if you click on I am injured in that area. So, for example, if you have a hamstring injury, it's very easy to teach them to start to do this on a regular basis. The app is called Skadefri in Norwegian, Fit to Play in English. Skadefri in Norwegian, Fit to Play in English. And then I'll go on here a little bit. And this is the Get Set app. Again, download for free. Made in 8 different languages and financed by the IOC. And here you can actually, I'll go through this very quickly. You can download exercises. You can create your own workouts. You can add to your favorites. And you can discover new exercises here. So this is for free. Take a look when you have time. And this is the Skadefri people. They are working with coaches, and they're working in schools in Norway. There are 11 sports schools in Norway for high schools, and these people travel around in those schools to increase the compliance when it comes to this stuff. So we're trying to train the teacher, train the trainer in how to get into this Get Set injury-free mode and to use it as a regular part of your coaching and also of your teaching students in your high school. So we do a lot of grassroots level sports club courses. We travel around to different sports clubs and do that. It seems to be working quite good because we do get the increase in the compliance. And the coaches, teachers, they change the training principles that they have been using. So there is a Norwegian National Coach Certification Program, 4 levels, and when we are active in all 4 of them. And we organize workshops, because I'm just going to show you some practical stuff now. Workshops, Sport Academy educational program, and this is what we do in the high schools. So basically, I'm an orthopedic surgeon. I operate on many of these. And I see that I don't get to everyone. Not much information has trickled down to the young boys and young girls. And this is why I changed my sort of interest going from all surgery, all ORs, into how to prevent these injuries to happen in the first place, and thereby secondarily preventing them to get arthritis at an early age. So this is the exercise of the week, for example, that we have every week. This is a Norwegian tennis player. He is number 4 in the world. Very good. So we send this out once a week. Yeah, same balance issue as you had, of course, Emmen. So they get that every week. So the take-home message is this. Risk reduction is possible. Implementation strategies are difficult, but can happen. Coach education and teacher education is very important, and you have to cooperate with them. Fit to Play and Get Set are tools that you can use, download for free, and use social media and role models for the young athletes. 50% reduction in the injuries if you do this very well. And that is really a very, very good result. Nordic hamstring, 67% reduction. Copenhagen adduction groin issues, 40% reduction. So you can reduce your injuries in your group that you're treating by about 50% by doing this. It's taken us a long time to get to that step, but it is possible. Thank you.
Thank you, Lars. I'll ask Lars to come back up and the other three speakers as well. And if you have any questions for this last group, Enda, Cherie, and Claire.
Just want to just put a plug in England. We're doing, or the Oxford and Reading area are doing this, the SKIP charity. I mentioned to you the Sports Injury Prevention Program, skipcharity.org, now badged as Power Up to Play. So there's a growing demand for this, and that's a program that's trying to capture. So we need to talk more about it with everyone around England to make this work.
Thanks. Yeah, I wonder what you think about, in relation to what the question was, the comment before, how do we get the message over to populations to prevent that first injury? Because whenever I show people who come into practice with overuse type of injuries, and I show them the FIFA 11 plus figure of knee position or the Netball Australia knee position, and I get people to look at themselves in the mirror, I'm pretty much the only person who's ever told them this, but they already, when they see it in the mirror, they start to work out for themselves how to solve that problem, and making the point that the knee position where the knee's going in and that the position we want to avoid, yeah, I'd say this is less efficient. Surely it's more efficient to be there. But once you set that problem, they do begin to solve it themselves. But how do you get this message over to whole populations?
I think from no one cares about injury prevention when they're not injured, ultimately, and like Lars has outlined very nicely, you need to get the buy-in and what's in it for me, and it needs to be, I mean, as clinicians, certainly most of the time we don't practice what we preach, so we don't do our own work, but I think it needs to be embedded within the environment and the culture of the organisations, and led by those who have the greatest influence, which is very often the coaches will dictate the structure of the sessions, and the coach's attention to detail and the environment that's provided will greatly influence that. So I think when you try to do it on an individual level, compliance drops off dramatically. And even that initial enthusiasm when they're injured drops off dramatically when they're back to play. I think the more it's embedded between this is just what we do, the benefits are clear, and how that's related back to outcomes and success and otherwise is probably the best way forward.
Just one comment there is social media. You know, these are youngsters. Social media is everything. Role models. You have to have role models, you know, top-level athletes speaking to the youngsters on social media on a very regular basis. That's how we do it. It does work. It's a lot of work to get those things together, but when you have it together, you can expect that this will increase your compliance.
Can I just say more in answer to that? So to understand, we know the prevention works. So we have the program that works. It's about implementation. What the SKIP charity, the Power Up to Play, has done is to take the PEP program, Bert Mandelsbaum program from 20 years, to make that into an exercise plan. The exercises are down there on the website. The concept is to train the coaches, to train the individuals to do it, just as you're doing in Norway, to make it work. But to get a public health campaign, then you need everything around it. We have the evidence before, and we need evidence afterwards to know that it works, which is kind of there. And then we need the media to make it happen. We need the role models, as we said, and we need money to make it work, to make a program that sticks, that rolls out to all the coaches and PE teachers at school, for the 8 to 10-year-old to 13-year-old who are malleable for neuromuscular training. That's what we want to get out there, to make that program, to go do it. So you'll see on the website the injury prevention exercises. But once you're into mainstream sport, then netball has the Jump High, Land Strong. Australia has the kneenetball.com.au website. And then rugby has Activate. Football has the FIFA Plus. Once you're in FIFA 11 Plus, once you're into the mainstream sports. But we need it out there for everyone in the 8-year-old when you can influence their neuromuscular control.
Can I go? Sorry, I just have a question regarding opt-knee consensus, if that's okay. I apologize in advance, I might have misunderstood it. But following ACL injury or traumatic knee injury, you mentioned something about imaging not routinely obtained, or was that?
No, this was more globally. If you're going to imaging, you want to make sure that you're getting imaging, and that's really because it's going to change your practice. So it's not specifically about diagnosing an ACL tear. It was generally in a rehabilitation program, if you're going to imaging, you want to be sure that it's making a difference to the care.
The reason behind me asking the question, because sometimes you come across these knee injuries in which, based on the history, it's very suggestive. However, when you examine the knee, the Lachman test is negative. And the reason behind it, because the knee is locked with displaced bucket handle tear. So sometimes the examination finding mislead people. So I was just thinking whether we should consider MRI and have low threshold for MRI scan.
Yeah, and I think, I think it's really down to, is it going to change the decision that you make as a clinician? And if the answer to that is yes, I think so, then by all means imaging is important. And we certainly acknowledge and appreciate that diagnosing meniscus tears is really important. We know that we can't get all of those on imaging either. So if you think it's going to make a difference to your clinical decision making, by all means, but make sure you're really asking yourself about that critically.
All right, I think we're going to wrap up this session, so big thank you to all of our speakers. Thank you.
So we enter the last part of our morning session. I'm delighted to welcome Steve Ewell. He's Chair of Behavioural Sciences here at the University of Edinburgh, and also Director of Human Factors at the Royal College of Surgeons of Edinburgh. And it was the best thing. First met Steve when I was asked by a member of my household to take the bins out, because he was my next door neighbour at the time. So good things can come from even being asked to do that.
Over the garden wall is very, very important place for starting collaborations, for sure. Well, it's a real pleasure to be here. Thanks for inviting me. It's a real honour to be on the programme. I'm actually here with Emma Howie, who I work with in Edinburgh. We're going to do a double act here, so I'll start off. We have no disclosures for this talk, but I'd like to acknowledge the funders, without whom none of this work would be possible, nor the lab group, who I'm very proud to lead as well. And this is a group of surgeons, social scientists, data scientists, really in Edinburgh and Boston, working on how to automate assessment of human factors and non-technical skills in surgery and in elite athletics. And so we're going to talk a little bit about NASA today, but also then talk about how we apply some of these tools and techniques to sports medicine. So I'm going to talk about human factors, what it is, why it's important to performance, going to illustrate some of NASA's approach to medical event management and how that's actually really similar in some ways to surgical management and perhaps in terms of elite athletics. And then we're going to talk about how we use some NASA sensors in sports management. And so human factors really is about two things. It's about optimizing performance and about enhancing well-being for people. It's about fitting the task to the human rather than cramming people into uncomfortable and unproductive spaces. It's critical in all walks of life, surgery, elite athletics, and also in space and space medicine. So NASA have a human factors division focused on design, technology, systems, training, all aspects about performance. And it's a very fixed, low resource medical environment. So this is International Space Station. This is actually the hospital bay on ISS. And there's some packs with medical equipment, very few. It's a fixed, low resource setting. The team also is not a multidisciplinary medical team. These are polymaths, one or two who might have physician-level qualifications, but these are scientists, life scientists, engineers, aviators, a real interesting group of people, but not a multidisciplinary medical team. And so we have looked at medical events in space, and I've been fortunate to lead some NASA collaborations for over the last few years. I thought this was really interesting to show you. So we're envisaging the potential for medical events on deep space missions to Mars. That's one of the aims of NASA. And I actually put this here because there are some things here you might recognize yourself, and apologies at the very back if it's challenging to see, but things to do with shoulder dislocation, things to do with the spine, also things to do with head injury as well. And these are ranked in terms of survivability in space. We saw some things yesterday that were actually pretty similar in terms of terrestrial settings. Now, one of our driving research questions is how do we support astronauts to manage medical events on long-duration missions? So mission to Mars is going to be 3 years, no chance of early return, a fixed low-resource setting, no chance of resupply, very limited payload in terms of medical supplies. The chance of a medical event happening, even in a very highly selected group, is still about 1. And we actually don't know what that medical event would be, but we have to try and prepare the team. Now, one of the critical challenges, though, is time delay. So ISS is about 1.3 seconds time delay. So that kind of frustrating thing when you have a delay on Zoom, you can kind of get through, you're speaking over each other, you can kind of get through that. On mission to Mars, it's going to be up to 45 minutes to have a return to a message from an expert or team of experts, flight surgeon on the ground. So actually you are an autonomous team, but not an autonomous medical care team. And if you have to deal with some potentially life-limiting health challenges, how are you going to organize yourself to do that? And so behavioral skills, non-technical skills, what we do actually at the college really well, you need those skills as well in space and in sports, and also simulation to try out some of these events. So here are non-technical skills for astronauts. We have similar systems in healthcare for different team members, in operating theatres, in the ward, in emergency medicine, and beyond. This really sets the standard for what are the behaviours that are required for high performance of medical events. What do you have to train and assess to be able to be competent to have autonomous teams to behave well in these areas? And this is published recently in the journal Human Factors. I'm going to show you a couple of examples of the medical scenarios. So you cannot train for all 80 of those potential life-threatening medical events. Not feasible. There's not actually enough time to train for those medical events in the space program, in the same way that medical students and surgical residents don't have the time to train for all potential eventualities. You have to kind of learn on the job. Learning on the job in space medicine is really hazardous. So here are 3 things: pneumothorax, eye blast, and ammonia gas leak. They all tap into different aspects, kind of transferable skills. So pneumothorax, being able to identify very early and swift action. Eye blast, being able to deal with psychological aspects of the crew. And ammonia gas leak, trading off human health and safety versus mission success, really kind of ethical challenges. And this is what the simulations look like. We built this simulator for training and feedback and assessment. Pretty realistic. It's actually the same dimensions as one of the modules on ISS, made out of the same equipment that the movie The Martian was made out in terms of the set. So it's like a movie set, but it's got a lot of the technology that is available in space, apart from gravity. We're still working on that. Now, one of the things that we've focused on here is how do you objectively assess those behaviors and team function? And NASA are very keen on continual monitoring of performance using biomarkers, especially for teams that are autonomous and are remote and are in space for 1, 2, 3 years. How do you gather continuous data to be able to predict their behavioral health and potential for medical events? One thing is using objective sensors of cognitive load. Emma, who's going to come up shortly to describe how we've used these sensors in a sports context, like one of the experts in the world on how these tools are used, what the literature says about how to really do automated assessment. One thing is heart rate variability. So everyone here, this is the kind of audience where everyone's going to have one of these watches or monitor your own health using this. We can hack into this, especially heart rate variability, electrodermal activity as validated metrics of cognitive load. And that's your available cognitive resource to meet task demands. And that's a really critical aspect. And we can start to measure this stuff in real time and look at the internal thought process, attention, stress, activation of people on task and how that fluctuates with actually what happens in front of you. how experts make decisions and how they use their cognitive load to do that. And with this knowledge, we can start to understand how trainees are able to develop those skills. So I don't know if this video plays. I don't know if you can make this video play at the back there. No, it's fine. So there's no video here. This is a still photograph. But it shows you medical simulator. And here Roger Diaz is in the kind of control room. He's one of my colleagues in Boston. He's measuring EEG, heart rate variability, and motion of the astronaut crew. And these are continuous metrics of performance, very different from an observer watching and assessing your performance or using a checklist or a rating scale. It gives us some objective data on the internal physiology. Now, this is my final slide before I hand over for how we apply these in sports context. But we have a surgical sabermetrics group in Edinburgh and Boston, really looking at how we can apply data science from surgery and athletics to be able to enhance performance using video and augmenting video with objective data from sensors to really have some much better insight into human performance and how we can intervene and support teams to excel in really challenging situations. So with that, I'm going to hand over to Emma. And now Emma's going to talk, as you come up, about our collaboration with the SRU and with what I call the real Murray brothers, Ian and Andrew, and James Robson and the group to talk about how we use these sensors for professional rugby. Emma.
Okay, thanks, Steve. Hi, everyone. So, performance in sport is well documented, it's well talked about, it's in the news every day, but it mainly focuses on the players and the coaches. But I would argue that the people in the background that are blurred out are equally important. The pitchside medics and the medical support team have got to treat injuries on pitch under difficult conditions. They've got to make decisions, and they're under a lot of strain that's potentially not discussed. And their sort of impact and their role in sports medicine is obviously clear to all of us at this conference, but it's not necessarily as advertised. I'm just going to play this little video, and so essentially what this shows is you've got the medics on pitch while game is happening in the bright orange there, and they're having to do their job assessing a player while game still goes on. So they've got to worry about the job they're doing, they've got to worry about a 160 kilogram rugby player falling into them or getting hit by a ball, they've got to worry about the crowds shouting things at different people. So being able to do that is actually pretty remarkable. And it's going to keep playing. Right. Steve mentioned a bit about what a cognitive load is. I see it as sort of our computer processor. So it's the capacity that we've got to carry out a task. We can measure it by looking at our autonomic nervous system, specifically our sympathetic, our fight or flight. And if we become cognitively overloaded, that can affect our performance. We're pretty good at adjusting for it sometimes, but if we are cognitively overloaded, it can lead to error, we can miss things. I don't know about you, but if you're trying to look for car parking space and you're listening to music, do you ever turn it down because you're trying to find a space? It's not that you can hear the space, it's more your brain is trying to adjust for that task that you're about to do, so it's redistributing resources by stopping you listening. There's lots of things that can affect our cognitive load. So we have internal factors. So you're hungry, you're tired, you want your lunch break at a conference. There's task-related factors. So you might be worried about the injury that you're assessing. And then there's lots of environmental factors. So mentioned about the crowd. You've also got players wondering what's going on. You've got your coach in your ear wondering what's going on. You might be working in a stadium that you've never been to before, with a team you've never worked with before, in a country that actually isn't your first language. So there's lots of things that can affect your cognitive load. So we did a study with the medics of the Scottish Rugby Union during the Six Nations, and we got them to wear a skin conductance response monitor. So it's just a wristwatch that you can see, sort of similar to an Apple Watch or a Fitbit, which I'm sure a lot of you are wearing now. And this is what the data might look like. So on the y-axis, you've got your skin conductance, your electrodermal activity, which is a sign of your autonomic activation. And at the bottom, it's the time of the game. So this is an aggregate for the 3 participants over all of the Six Nations games, and it shows some interesting patterns. It's difficult to compare individuals' skin conductance like for like because there's lots of different things that affect it, like skin thickness and things, but so you can't say that the top person's got higher cognitive load than the bottom 2, but you can see that their cognitive load changes throughout. And there's some patterns that we can look at. So at the start of the game, on the left there, activation's high, we're preparing to get ready for the match. And then at half-time, again, there's more activity, there's assessments, there's treatments, and again, that's putting our cognitive load up. So what this might look like for one individual over one game is something like this. So again, sort of the higher the peaks, the higher cognitive load and the higher skin conductance. The arrows are corresponding to some activity that was happening during the game. So we've picked out some tries and some penalties. And you can see again, so before the match, cognitive load is quite high. There's a lull during the national anthem. And then the activity goes on, and the highest peaks are sort of at the start and during half-time when there's the most activity. And I'm just going to focus in on the area in purple here now, which shows you a period of 5 minutes of when a player was injured. So at A is a point where a player was tackled, and at B, this player got taken off for head injury assessment. And it shows all the different peaks. And what's interesting about this is there's sort of increased activity before A because of activity on the pitch. And then at A, the tackle happens, and then the medic sort of shifts into gear. The resources are allocated to assessing the player, making those decisions. So they're focused, so it goes back down, and then it starts climbing back up when they've got to communicate that decision. And I've got another video that hopefully works that shows this here. So this is real-time cognitive load skin conductance data on the left there, which is changing in response to activity on the pitch.
The kick rally. And Russell thinks he sees a bit of space between the 2 men in the backfield, and bigger to Williams. So looking for long
I'm
kicks
sorry,
and
the
then
score
short
doesn't
or
change no matter
contestable
how
ones
many
like
times
this
you
one
watch
from
it.
Liam Williams. Can't quite take it himself. Bouncing there for Hogg. But
What you
Williams
can see is the
gets
activity
his
on the
opposite
pitch
number
is
down.
happening, the cognitive load is changing, and they're responding to well, the things that they can't control for. So and it's exciting watching a game and being part of that team.
Disruption in the pass, but it still works okay for Scotland, and there's a bit of space back there. Rio Dyer scuttles back. And then the pass is loose, now real danger for Wales. Sits up now for Biggar, and then he slices it in Biggar and Dyer, the senior man to the junior, with a bit of a bark and a snap.
Great kick chase from Scotland, mind. The reason
what we're about to see is the cognitive load about to go back up again, like we saw in the still graph.
Pushed it a little bit too far forwards for Dan Biggar, but then following this, 4 Scottish players breathing down his neck to force the kick early in the touch.
And it's peaks when the medic's signalling this player needs to come off.
Treatment ahead.
And it's a big decision to make.
The mouth of Stuart Hogg. So
I've got some more videos showing you from different participants. So it's not just one person, it happens for everyone. So some of these videos are a bit sped up and they'll slow down. So again, cognitive loads, skin conductance in the top right here is changing in real time. It's responding to the on-pitch activity. And as Ireland unfortunately score a try, which did get not counted, which is good, the cognitive load goes up completely. And you're about to see what happens when things change a bit. It's about to slow down. And if you just watch sort of behind the try line when it catches up. You see a little peak here. It's because that medic has been performing an assessment. So you can see that they had lots of activation whilst the try was happening, but it was controlled while they were doing their assessment. And again, this is a line out, which is something that they can't predict for and can't control, and their cognitive load is going up. I'll skip this one. And then, so this is our third participant, so it shows similar. So things are calm, things are controlled. There's activity going on, but there's no tries, there's no penalties, things aren't going up. And then here, you carrying out another assessment. So his cognitive load goes up a little bit, keeps going up. This assessment lasts for about a minute. And things are controlled. He's probably communicating to the coaches what's going on, things are okay. And then as he's about to leave the pitch, his cognitive load is returning to normal before play starts again. And as play starts again, just watch and see what happens with his graft. And you can see as another sort of unexpected activities going on, the cognitive load is getting higher again. So it's really interesting to see how you can control your activation without even realising it during critical points. And that's something we can learn from in surgery as well. So thank you for listening. I hope I've convinced you that you can see that there's some team synchronicity within the medical team. So their cognitive loads sort of change at similar points and in response to similar things. And that we can see from this that they're actually very good at controlling their cognitive load and their autonomic activation. That's not always the case. And we've seen that in medicine. But when you're an expert, you can do it. So thank you for listening.
Any questions for Steve and Emma about that work? So, Steve or Emma, can I just ask, what is the has anyone done that you're aware of this work in other areas, looking really at team performance using these measures for medical teams?
Yeah, so it's quite a lot. So a lot of the research that Steve has done originally in the States and Boston has looked at heart rate variability. We're actually doing this work in Edinburgh as well. So I'm using skin conductance to look at the surgical team in Edinburgh. So it's been done in medicine. It's been done a lot of computer science studies have used it, lots of driving sort of thing. So it's been done in lots of different fields and it's coming into medicine now and we're hoping to pioneer it as well. So.
I'd add to that, Ian, as well. I mean, there's a lot of opportunity here to embed these in every walk of life for, not just for individual cases or exciting matches, but it should be used everywhere for training and assessment and development. I mean, this could be widespread. We're just working on the computation, how to do it in real time and how to scale it. If we can use it with very off-the-shelf devices, then it becomes an inexpensive way of understanding performance.
Great, thanks very much. Question from Niall?
Yeah, thank you very much. Fascinating. And just to sort of parallel the work that you've done, this is obviously objective measuring and trying to get data, hard data. We've done work in subjective measuring within teams going to Olympic Games and Commonwealth Games, and actually just measuring sleep quality, motivation, energy levels, stress levels, self-reported. And it's fascinating just to see that timescale over the 2 weeks. Reportedly, we know that athletes get knackered and pick up coughs and colds in the second week. Staff underperform in the second week. And that's where we then start to make bad decisions in the high-pressured environment. So it would be lovely to marry objective and subjective matters with this. So well done. That looks fascinating.
Thank you. Yeah, and that's something we try and do in surgery. So we try and marry objective and subjective measures and things like sleep and stress.
Great. Well, thanks very much, and thanks to everyone for participating this morning. We're going to reconvene at 1:30.